On behalf of UT Health Houston and UT Tyler, I and Dr. Kevin Moore, we would like to welcome you all to this second annual Southwest Center's Symposium. We are more than thrilled to announce that this is our second joint effort as two institutions that are working really hard and together to disseminate science on occupational health and safety to you all. And we really appreciate you all taking your times out for attending this symposium. With that said, I would like to recognize a few people here. Ms. Sylvia Santiago is our research program coordinator at the UT Health Houston campus. And as you can see her name, she has been an exceptional person, and she's the one who is really working hard behind the scenes to make sure everything happens smoothly. And this is, it's such great that this hall is happening together. It's all a great coordination of work that has been done by both the institutions so far. So I won't take too much of the time, but just to let you all know that this is the 24th year that the CDC NIOSH has been funding the Pilot Projects Research Training Program at the UT Health Houston campus, and over $1.4 million have been dispensed, and they have been awarded to our center continuously over the past 22 years for making these pilot projects happen. And we have been very, very successful over the past 2 decades in disseminating the science and conducting the projects year round. And this is just a great day to be together and get the information. So that's a little bit in a nutshell about the Southwest Center for Occupational Environmental at UT Houston. But I'm passing along to my co-host and the director of the UT Tyler Ag Center, Dr. Kevin Moore, so he can go ahead and introduce a little bit, give a little welcome note, and also introduce our keynote speaker today, Dr. Paul Schulte, who was spending some valuable time to be here, and we're looking forward to that presentation. So without wasting any time, I'll pass it to you, Kevin. Yeah.
Great. Thank you very much, Janelle. Again, my name is Kevin Moore, and I direct the Pilot Feasibility Studies program for the Southwest Center for Agricultural Health, Injury Prevention, and Education. We usually just call it the Southwest Ag Center because just like Janelle was saying, our names are very long, but excited to be here, excited to have the second year of this partnership continuing. We were formed in 1995, and so the Southwest Ag Center operates out of the University of Texas at Tyler Health Science Center. And we've served the sort of 5-state region surrounding Texas, so Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. And so our programs are quite similar in the role that they serve, but our program is focused on agricultural safety and health. And so our goal is really to try and, with the Pilot Feasibility Studies project, our goal is really to try and support and promote the development of new researchers within ag safety and health research topics, and to also try to help promote emerging science and emerging issues. So we are really pleased to partner and try to see if we can't promote the activities of our scientists who are working on these important topics, and find new ways to network and find great opportunities to help people know more about our science and the work that's being done. I'm very pleased to have the opportunity to have Dr. Paul Schulte to join us. Dr. Paul Schulte is a consultant and former director of the Division of Science Integration and co-manager of the Nanotechnology Research Center at the National Institute for Occupational Safety and Health, or NIOSH. Dr. Schulte has 40 years of experience in conducting research and developing guidance on occupational cancer, nanomaterials, risk communication, workplace well-being, and genetics. He also has examined the convergence of occupational safety and health and green chemistry and sustainability. He is the co-editor of the textbook, Molecular Epidemiology, Principles and Practices. Dr. Schulte has served as guest editor of the Journal of Occupational Medicine and the American Journal of Industrial Medicine, and was on the initial editorial board of Cancer Epidemiology, Biomarkers and Prevention. He is currently on the International Advisory Board of the Annals of Occupational Hygiene. Dr. Schulte has developed various frameworks for addressing the aging workforce, burden of occupational disease and injury, well-being of the workforce, translation research, synthetic biology, and occupational risk. And I've had some opportunities to work with Dr. Schulte over the last couple of years with an IPA project that I've been engaged in as part of CDC NIOSH. He's been a great colleague, and I know that you will all enjoy his comments this morning as he kicks off our symposium. So Dr. Schulte, thank you so much for joining us. We'll let you go ahead and share your slides and get started on your presentation.
And before Dr. Schulte starts his presentation, just a brief announcement, okay? So we would also like to recognize the directors of both these centers. So the director of our UT Health Houston Southwest Center for Occupational and Environmental Health is Dr. David Jimeno. And the director of the UT Tyler X Center is Dr. Vanessa Casanova, who will be joining us shortly. So they're all working together along with us, and Sylvia and Amanda Wickman from UT Tyler. We're all working together to make this whole thing happen. So thank you everyone for being a part of this whole symposium. And also very minor announcement that the WebEx has been upgraded recently, so you may not be able to see the other attendees here on the call. We have close to 42 attendees right now, along with the panelists that you can see. So if you have any questions, just raise your hand. You should be able to use the chat box, and we should be, one of the panelists should be able to unmute you and ask the questions. So just some brief housekeeping announcements. With that, I'll let you go on, Dr. Schulte. Thank you.
Okay, thank you. It's a real honor to be here. I particularly like these kind of events because it's a chance to talk with students. And I'm going to be talking about the future of the field of occupational safety and health. And you, the students, are going to be that future. And so I'm going to broach with you today two concepts, well-being and decent work, and talk about where they might fit in occupational safety and health. And this is sort of an overview of what I'm going to talk about. I'm going to go through, first of all, the changing nature of the world of work in terms of work, the workforce, and the workplace. And I'm going to call for an expanded focus for our field to address these changes and the future of work. And we'll do that with special emphasis on the concepts of decent work and well-being. Now, change in the world is happening at such rapid speed that it's constituting potential situations where there could be new hazards for workers. The safety and health of workers may be affected by these changes. And so as you go out and practice, do research, develop policy, be practitioners, you're going to be working in this next period between now and the next two generations worth of time up into the 2050s. And so the world is only going to get more like we're seeing now. The changes that we're seeing now are likely to occur to an even greater extent. And so it's imperative that we think about what this space is between now and the farther future. And so let me go through the changing nature of work. One of the major drivers of this change is the on this graph. And indeed, these changes are affecting the nature of work. And I don't have to belabor that point with you all. But I have to change my slide here. So what we're going to see are new scenarios of work. We're going to see a transition from relatively standardized work and working patterns to more complex and diversified working environments. We're going to see more digital skills and new uses of data that will be the core of jobs of the future, as they are of some of the jobs now. The whole idea of an employment contract, the relationship between a worker and an employer, is evolving and will continue to evolve. And indeed, we as practitioners of occupational safety and health are faced with the task that many of the jobs that we're going to have to consider and deal with do not even yet exist. And so we need to be flexible and nimble and prepared to deal with new jobs and potential new hazards. This is a classic paper from Fry and Osborne from 2013 that looked at 702 occupations and using their analyses showed that at least 47% were at high risk of being computerized. And the computerization of jobs may lead to unemployment for some workers, and that's a tension right there. In any event, it calls for skilling and upskilling and continuous skilling of workers to be able to be competitive and productive in the future economy. And as I said, this computerization of jobs is eroding a lot of the middle class jobs and leading to a job polarization. Jobs in the low skill area and jobs in the high skill area seem to be somewhat stable, but the number of jobs in the middle area, middle managers and different kinds of occupations are lessening. And there's a lot of different takes on technology and its impact on the world of work. One is sort of a dystopian one that will displace 400 million jobs globally. One is more utopian that says it will create many new jobs. In any event, there's going to be a mismatch between technology and skills, and it's going to require worker training and retraining and lifelong learning. And just to note, I'm not just talking about those workers, I'm talking about us as workers. We in the occupational safety and health field are going to have to continually upgrade our knowledge base to deal with these situations. We know that a lot of this is going to happen because we've had a bit of a international experiment, the pandemic. It's shown what can happen when you have a decentralization of work, and it's essentially accelerating future trends. We're seeing increased incidence of anxiety, stress, fear, and depression. We're seeing disparate impacts by race and socioeconomic status. And we need to be careful not to let our thinking devolve that everybody works at home with their computer. That's not what a lot of workers do. There's the deskless workforce, the people who are on the front lines, who don't have the luxury of working from home. And those people are going to continue to be working, even as many people are working in a decentralized way in their own homes. So we saw a lot of this with the pandemic. Interestingly, the literature up until this pandemic didn't really have much on the impact of pandemics on work. And now it's a major topic. We did a study that we looked for scenarios, potential scenarios of the future of work. And we did a large literature investigation. and had various criteria, and found 17 studies that really identified and provided scenarios for the future of work, and either provided the hazards that were there or that they inferred would be there, or we inferred the hazards based on their discussion. And indeed, what we saw was increasingly psychosocial hazards are going to be the major type of hazards that are going to occur in the future of work. Not that the other hazards won't be there, but the growth and the impact will be likely to be in the psychosocial area. And this is the kind of things we saw in the literature of the psychosocial hazards. A variety stemming from stressful interactions with automation, particularly robots, anxiety about employment and careers, decreased situational awareness, blurred work-home boundaries, work intensification due to fast pacing, use of electronic means to monitor workers, leading to potential privacy invasion, working decentralized and through screens, leading to loss of social skills. You could add in here loneliness too as a growing condition that is in some ways reaching epidemic proportions in many countries. To focus and cope in this kind of world, we're going to see the potential for more performance-enhancing drugs, as well as performance-enhancing physical things like exoskeletons, all of which have their negative side effects on worker safety and health. And all of this taken together leads to an assault on the dignity of the worker. Now, the computerization of work historically has been thought to be depicted by what's known as the routinization hypothesis. And that is that if you look at skills and tasks, it's the ones that are routine, be they cognitive or manual, that are likely to be computerized or in some ways changed. Now, maybe not the whole job, but certain tasks in the job. This will be a driver for the need for upskilling and lifelong learning. What the Fry and Osborne paper showed, that possibly even some of the non-routine tasks might be susceptible to computerization. So indeed, but this is the major one, the routine jobs. Here are some data from Australia, and they pertain generally, I think, to most industrial countries and probably even some of the developing countries. But you can see the two downward lines are this is the employment share of employment, and the two downward lines are the routine task types of employment, and the ones that are growing are the non-routine, both cognitive and manual. Now, a lot of this kind of psychosocial stress that we see, that I've been talking about, has the potential to lead to adverse cognitive effects. And that is critical because also we have an aging population, and age also leads to adverse cognitive effects. So I'll talk a bit more about that in a minute. Here's another take on a model that shows a pathway from work to physical and psychological health through a stress pathway, indirect stress pathway. There's also direct physical pathways as well. Now, that was the composition, that was the changing nature of work, but let's look at the changing nature of the workforce. And indeed, it may be changing even more than the nature of work. We're going to see in the workforce increasing numbers of older workers. We're going to see more immigrants, more women, more veterans. increasingly a multi-generational workforce. Right now, there are essentially 5 generations. And it's likely to continue for a while. And we're going to see more people with chronic disease. And that's a critical backdrop to looking at the workforce. But the big thing for the workforce of the future is that it's going to be an aging workforce. These are demographic population pyramids. This is from 1900 to 2050. The classic population pyramid is pyramidal in shape, but we're now coming into what's known as the rectangularization of the population, or I like to think of it more as a barrel. But in any event, you almost have the same number of people at each age group. And indeed, we don't have a diminution at the top like we did historically. So we're going to have a lot more older workers that we're going to be needing to think about. And that has implications for society. Back in the 1950s, the older workers and their societal needs, pensions, Social Security, etc., were paid for by 5 workers. Every one older worker was supported by 5 workers. By 2030, it's going to be every 3 workers. This is going to put the bite on these 3 workers. They're going to be a bit disconcerted by the strain to maintain the older workers. But indeed, that's the societal problem we're going to be facing. People are working longer, and because of that, and because there are so many of whom are not working longer but retiring, some countries have extended the age of eligibility for pensions. People may have to work longer for economic reasons, as their pension may be inadequate to keep their health insurance because they lack savings. Some people work longer because they still get a major sense of satisfaction from their work. But there are negative consequences of working longer. Older workers don't necessarily get more injuries, but when they do, they're often more severe. There's also the potential for burnout, job lock, where you are locked in a job without the ability to advance. Age discrimination is increasingly a problem. Job insecurity and unemployment as a result of age discrimination. If a person's working longer, then they have obviously less non-work time to do other things, and they have continued exposure to hazards. Essentially, the cumulative effect of all the hazards that they've been exposed to in some ways continues. This is from the National Academies of Sciences to depict aging in terms of the center line, which is the normal aging. And throughout life, various faculties diminish to some extent. And depending on the inputs in your life and the way you live, you can be above this line, have optimal aging, but there can be exposures throughout this period that bend the line down to some disease threshold. The whole concept of cumulative risk assessment in the exposome captures these concepts and challenges us to, in the occupational safety and health field, in the environmental health field, to look at the accumulation of risk factors over time. And I'll talk more about that a little later. Another feature to realize is that with the aging worker, aging in general involves a change in cognitive capabilities. And there's 2 types of intelligence. There's crystallized intelligence and fluid intelligence. And this is a simplistic take on it. And indeed, the crystallized intelligence continues to grow as a person ages. This is based on a person's experience, their knowledge, the things that they've done in their lives. And then there's the fluid intelligence, which is more the intelligence that's brought to bear when new problems occur and a person needs to solve them. And so this has a bit of a downturn. Now, this is the average. Not every person will have these curves looking like this, and these curves can be bent in different directions. I'm giving you all this because this is the backdrop of the workforce of the future that we're going to have to deal with. And one of the questions that people say, well, will this decrease in productivity? The green line is productivity of workers on an assembly line in Germany. Essentially, their productivity as they age doesn't go down. In fact, it goes up. But there is literature that shows job performance does, in some types of jobs, decrease at older ages, but not for all tasks. It may be less important in occupations where there are abilities needed that don't decline by age, but it could be a critical feature in some kind of safety critical jobs. In any event, there will be need for more training, better work organization, and more flexible systems to allow older workers to continue to work and benefit from their comparative age advantage. In other words, the crystallized intelligence. We also have another backdrop issue. In addition to work and aging, we have work and aging and some people with chronic disease. And indeed, chronic disease burden is huge. These are data from 2007 showing the combined direct and indirect costs of chronic disease on society is 1.1 trillion. Here's another slide from 2016. It's up to 3.7 trillion. The big thing about chronic disease is its role in this productivity triangle. The biggest area in this triangle is presenteeism. These are 2004 data, but they're still quite apropos to today. Occupational safety and health hazard, short-term disability, or even long-term disability was a much smaller part than productivity. Or absenteeism is a much smaller part. So presenteeism is people who go to work but aren't fully functional, in part because of chronic disease, but also could be in part because of underemployment, that they're not being challenged or stimulated. The occupational safety and health field has to think about dealing with this triangle as well, and the presenteeism part as well as these parts. And as a society, we're going to have to deal with this because we're hemorrhaging. We're losing economic output due to chronic disease. And here by 2050, this estimate says we'll be losing $6 trillion in foregone output. Now the workplace is changing too. And we're going to have to adjust to it. And we've had, in part, seen that in the pandemic. We're having more decentralized workplaces. Again, remember what I said about there's many people working in the front lines, but we still have many more decentralized workplaces, more hybrid models where people work at home and at the office. And we're seeing a lot of that now. And the shock in American and other societies of that workers don't necessarily want to spend 45 minutes commuting each way when they can work from home. So companies are dealing with the tension of working at home and working at the office. That will result in the reimagination of the physical spaces where people work. And in some cases, if people don't come to the office, they may have less access to the opportunities of than those who stay at home. I'm talking about everything from hallway chats to direct access to employers in physical ways. walking down hallways, sticking heads in offices, things like that, where a lot of business opportunities rise and fall. Another thing that's going to affect the workplace, maybe the biggest thing, maybe the biggest existential threat that we face, is the influence of climate on the workplace. And it's increasingly becoming a larger hazard. And for a long time, while there's good 20, 30, 40 years of literature about climate and then climate change, occupational safety and health hadn't been thought of comprehensively. There is some literature on heat effects, but generally not much on occupational safety and health. So in 2009, we started examining the literature, saw that there was a broad range of individual hazards, but there wasn't a comprehensive view of climate change as generating occupational hazards. We put together this simplistic model that between climate and health and safety effects, there were these 7 categories of hazards, many of which happen simultaneously or can happen simultaneously or over a working lifetime. So increased temperature, ambient temperature, increased air pollution, UV radiation increases in extreme weather, expansion of vector-borne diseases and biologic habitats, the impact of industrial transitions and emerging industries in relation to climate, and changes in the built environment. And so we've done a series of papers addressing those hazards. And workers are more at risk of the hazards and health effects from climate change because they're likely to have more and greater exposure than the general public to these hazards. Secondly, employers are used to maybe managing a safe workplace, safe and healthy workplace, with the things that are in their workplace, but the things that they produce or the situations that they control, but they don't necessarily control the climate. They're not used to managing and protecting workers on the basis of climatic changes. So this adds to the risk of workers. And many of the plans that states and other organizations have developed to respond to climate change haven't really identified workers. And this is a neglect that needs to be remedied. And just to reiterate what I said before, the workplace of the future is going to be a mosaic. So we're going to have changes that I've just been talking about in the workforce and the workplace, but we're still going to face the same older and deadly hazards and risks. And we're going to have to deal with them. Some may be in new situations, but still we're going to have to deal with them. And climate could be increasingly a significant factor. Now I'm going to talk a bit about decent work and well-being. Decent work is work that respects the fundamental rights of workers in terms of their work, safety, health, remuneration, respect, and the exercise of their employment. And so indeed, it is a high target, a good target that the ILO and the UN have identified for countries of the world to work toward. And the UN developed a series of sustainable goals for 2030, and goal number 8 is decent work and economic growth. And that is an area that I'm talking about when I say decent work. And essentially the ILO had 4 objectives or pillars of decent work: employment creation, social protection, rights of workers, and social dialogue. I worked with a group of people at the International Commission on Occupational Health to identify determinants of decent work. And they're on this side: new and emerging hazards, demographics, particularly aging and gender, globalization, informal work, migration, pandemics, climate change, and workplace policies. And our contention is that occupational safety and health has to assess what it can do, what it can contribute, what skills are needed at the intersection in each of the boxes in this matrix. And that's the challenge for the future. And to do this, we're going to have to expand our skill sets and our way of doing business. And I'm going to show you that a bit. And part of this expanded focus is depicted in this slide. It's a model we developed that we call expansion horizontally and expansion horizontally and vertically. The horizontal expansion involves not only having the skills of traditional and focus of traditional occupational safety and health, but having an understanding of the interaction of personal risk factors with occupational risk factors and the impact of social and economic risk factors on work situations. So we need to focus this our thinking in this horizontal direction. That means we need to think about not only classic occupational diseases, but work-related occupational diseases. And work-related ones are ones where the etiology is partly affected by work-related factors, but partly not. And in some cases, if you're thinking of it in terms of attributable fraction is approximately less than 50% for these. But this is an area that we haven't thought about that much historically in occupational safety and health. We've been on the other side, and now we're suggesting that we're going to need both of those things. We also need to go and think in what we call the vertical direction, and there's two components there. One is the working life continuum needs to be thought of. In other words, not just one job that a person has, but all the jobs they have in their lives. And increasingly, people are having more jobs in their lives than ever before. And so the occupational safety and health field needs to start thinking more of the totality of the working life rather than just what's happening in a particular job. And the totality of the working life also means paying attention to what happens between jobs, the health effects of unemployment, and what happens on jobs when people aren't working to their full capacity, the health effects of underemployment, and the anxieties that can arise from losing jobs or potentially being poised to lose a job in terms of precarious employment. We know there's a strong literature on the health effects of underemployment. Here, this shows some of that, of unemployment. This shows some of the information on that. Underemployment seems to have the same effects as unemployment. And so that's a growing area of study. And then all of this needs to be, we need a way to capture all of this. And one overarching concept is the concept of well-being. Historically, though, we've talked about well-being as a conjunctive phrase, health and well-being. Well, that's not going to cut it if we're going to really use well-being as a holistic concept. We need to, it has all these definitions and includes health, but it also includes flourishing, aspiring to a good life, and it's related to productivity at all levels. And so we're going to need to operationalize well-being, and we're going to need to investigate it in terms of the factors that promote it and the factors that threaten it or prevent it. And all these arrows that are shown in here, the dotted ones and the solid ones, could be pathways for research or investigation. And indeed, well-being, when operationalized, could be utilized in terms of research, practice, and policy. And I think I'm running low on time, so I'm not going to go into this, but you can see there's different ways to use well-being if it was operationalized, everything from variables in research to targets and goals and policy. Doing this leads to a variety of questions that we're going to have to wrestle with. How to find the instruments that will allow us to operationalize well-being. We're going to be talking about a lot of things that historically aren't in occupational safety and health, and privacy is going to be a big issue. And then interpreting and utilizing the results is going to be a lot more complex than historically we've had to deal with. Dame Carol Black in 2007 said that there's strong and growing evidence that work health and well-being are closely and powerfully linked, and they need to be addressed together. NIOSH has done this with the Total Worker Health Program. It has a new questionnaire that's now on the website that might be useful. It has 5 domains. It's called the WellBQ. And you can see in the Total Worker Health literature of NIOSH that it's starting to recognize the complexity of the world of work and the areas where occupational safety and health need to expand. Finally, this is just to show that we need to work more. If we're going to make a difference in the world of work, we need to be focusing more downstream from the basic and applied research to think about how decision makers get and use occupational safety and health information. And we have a couple papers that we've done with this. And with that, I thank you for your attention and hope this has been useful.
Dr. Schulte, thank you so much for your overview. I know I took a lot of notes thinking about some potential future research directions that I might like to consider, and I want to dig back into your slides a little bit more and refresh my knowledge on a few areas. But I expect we'll have a few people that will ask if we can share your slides. I don't know if you have any objections to that, but we can talk about that maybe after the meeting.
Yeah, no, I can tell you right now, the slides, anyone can use them.
Okay, great. Thank you. I do want to just let you answer one quick question that I know that I saw in the chat, asking about any demographic differences in the risk of adverse mental health consequences that are based on age. So looking at that aging population, are there any demographic differences in mental health consequences and risk?
Yes, I'm sure there are. I mean, that's already the age demographic and data shows that older workers are more susceptible to mental health consequences than younger workers. That doesn't mean that there aren't mental health consequences in younger workers. Indeed, we're seeing an epidemic in the population of young people having mental health issues. And so the subset of that group that are young workers, indeed, will be bringing those pressures and issues to work, and that will be added to the hazards that arise from work. And you could go on and speciate demographics even more, but that's yes. The answer to that question is yes, in a lot of different ways.
Well, and one other thing that I was reflecting on, this idea of the challenge of presenteeism combined with more online work, more non-traditional work environments, definitely is a unique challenge to try to deal with. How do you address issues of productivity in a more diversified sort of a work environment where a number of people are working remotely? How do you deal with work-life balance? All those challenges are sort of related to that topic as well.
Right. And there's two concepts that I didn't mention, but are critical for that answer and a lot of others of how we're going to deal with all this. One is that we have to have in our curricula more systems thinking types of training to learn the multiple levels of systems and how disparate parts interact and how to study that. Secondly, we need to increase our skills in transdisciplinary functioning. That means not just interdisciplinary or multidisciplinary, but where we in the occupational safety and health field learn the language of other disciplines, learn how to respect their paradigms, and then engage with them to jointly address problems. and all of us using a systems thinking approach, and then the skills of those disciplines interacting is going to be critical for addressing these kinds of problems.
That's great. Well, thank you again so much for your contribution this morning, and your willingness to sort of set a broad stage for us in thinking about the future challenges that we're going to face in occupational safety and health. In the interest of time, I do want to go ahead and hand things over to Dr. Vanessa Casanova. Dr. Casanova is going to be sharing with us the sort of introduction to our Ignite presentation format, and she's going to sort of help set the stage as well for our first group of presenters that will be presenting their work today. So I will turn it over to Dr. Casanova.
Good morning, everyone. First of all, thank you, Dr. Schulte, for such a compelling presentation, particularly on the changing nature of the workforce and the aging of workers, which are both really prominent issues in agriculture. I'm Vanessa Casanova. I'm the director of the Southwest Center for Agricultural Health, Injury Prevention, and Education, and associate professor at the University of Texas at Tyler Health Science Center. Let me just say we are delighted that you all are here for the second annual Joint Pilot Feasibility Studies Symposium. In order to highlight the importance of the work undertaken by each of our PIs and to take advantage of the collaboration between the ERC and the Ag Center, we're going to be using an Ignite Talks format. We did this last year and it was quite successful. Ignite is all about fast and fun presentations. Each of our speakers have created their presentations with 20 slides, each of which will be shown for 15 seconds and advanced automatically, giving each speaker about 5 minutes to talk on their respective research. We've organized the symposium by creating thematic clusters, resulting in 3 sessions, and we're reserving about 20 minutes at the end of each session for discussion. So please engage with our researchers by typing your questions in the Q&A box. And each session will be moderated by staff. Okay, so are we free to get started? I think we are. I think our start time was 9:15 for this particular session. This session is Perceptions and Barriers to Health Decisions. And we have Dr. Shannon Guillot-Wright, Kimberly Prado, and Luann Ratcher are going to give their talks in this session. And I believe that we are controlling the slides on our end.
Sylvia should have those queued up already.
Super. All right, then let's get started.
Just to add, Dr. Casanova,
Yes.
Kim Prado may not be here today. She just recently came out of her medical leave. So if you have any questions, she will be extending her project and also will be presenting the next symposium. But if there are any direct questions for her presentation, she was kind enough to send us her presentation.
Good. So we have the presentation, just not the PI. Excellent.
Yes.
Okay.
So we can share her email with anyone who has questions after the presentation, for sure.
Thanks, Janelle. All right, so first up is Shannon Guillot-Wright. She's at the University of Texas Medical Branch, and I will let her take it away. Thank you.
Hey Sylvia, we're not able to hear any audio, so you might have to click on that share button on WebEx and turn on the audio feature.
Wright, Vice Chair of Research and Health Policy, and an assistant professor in the Department of Family Medicine at UTMB. And today I'm talking about neoliberalism and its impact for Gulf Coast fishermen's health. So to start, we're going to talk about commercial fishing and how it's one of the most dangerous occupations. And the secondary data analysis that we conducted using fishermen's oral histories to really try to understand and get underneath structural and social determinants of health. And then we'll discuss our findings that federal deregulation of waterfront development, offshore oil development and oil prices, and seafood impacts have impacted the health of fishermen. So how do policies impact individual health outcomes? That was our main research question that we were trying to get under. And really what we wanted to do was look at not only individual health disparities. So like I said, fishermen have some of the highest non-fatal and fatal rates of injury among occupations in the U.S., including falls overboard and vessel disasters. But we also wanted to understand what are the structural factors, what can be called structural violence, and the social determinants of health. How could those be used to really guide our thinking in this space? So our methodology that we used, we had a secondary data analysis. We used an analytic expansion typology that's really about making sure that you're looking at a different research question from that in the primary study, using a subset of cases, re-examining concepts not addressed in the primary study. And then we collected it as pilot data to define and expand future research questions. And our qualitative methods approach was really a two-stage process. So first we coded the transcripts in Atlas TI using an inductive approach to find key themes and discourses that emerged. And then I reread the transcripts using an interpretive analysis approach to really develop a more complete and data-driven theoretical framework. And what this did is it allowed us to really look at the political, economic, and social interactions of the fishermen. So here are a few quotes that we pulled out from the oral history. So this person said, "Fishermen are dwindling because they can't make a living anymore. Their boats are, both of my boats right now need to go in the shipyard. I can't afford to put either one of them on the shipyard. We can't afford to work on our boats. We can't afford the repair. We can't afford new equipment. We can't afford boards. We can't afford trawls." This person said, "A lot of fishermen have voiced to me that one of their main concerns was safety at sea when they're out at sea, especially in this economy, how they don't have the financial money to actually put more maintenance into their boats, much less, consider their safety." And here someone said, another interviewee started wearing earplugs because a lot of people wouldn't fix the machines that had bearings, and his ears started ringing. So what we found was waterfront and coastal development deregulation. So fishermen and their families were really concerned about the deregulation of waterfront development, how it increased pollution and property taxes and decreased fishing business. So this person said, "My husband has been a commercial crabber for 30 years. The crabbing business is terrible because of pollution and that the river was being destroyed." Someone else said the casinos have been devastating to the commercial fishermen because they took our docks, and that most of the shops and seafood processors had closed down and they sold out to casinos. And then we also had a theme of oil deregulation. So this included oil spills and fuel prices, such as the BP Horizon oil spill. So these people said, "We're just barely holding on. The fuel is so high right now and it's taking so much of our profit. You have to make $3,000 to $4,000 worth of expenses to get out. You're barely making profit now. You're just breaking out even." For the BP oil spill, somebody talked about how they were sprayed with Corexit and how we got our water sprayed daily, nightly for hundreds of days. And this person went on to talk about their brother ended up getting pretty sick from this. Then we need stricter management of how the oil is brought in and what safety managers are there, especially when we realize things like oil spills can occur, hurricanes can cause problems, and just the environmental changes itself, the effect on it. We need to keep all that in mind. Our next result that we looked at was import deregulation. So imported shrimp really flooding the U.S. market and making shrimp prices tank. So this person said, I'd say in the early 2000s or maybe the late 1990s, we used to get like $2 and something a pound for 40 or 50s. Now you're lucky to get 80 cents. And then really talks about how the price of gas, so this brings back the fuel prices, and how that really impacted how much they could sell their shrimp, especially with the shrimp imports flooding the market. So what we looked at then, our theory that we saw these results through was precarious employment and neoliberal ideals. So the logic of this unregulated industry and precarious employment grows out of capitalism, but we really see that more fully realized through the growing influence and consensus of neoliberal globalization. So neoliberalism really became prominent in the 80s, and it really motivated ideals of industry deregulation, decreased labor power, free enterprise, and advanced notions of personal responsibility. So you have economic policies, as the interviews discussed, that directly or indirectly created and sustained poverty through oil development, through oil deregulation, pricing, and fish imports, which has contributed to the decline in income and subsequent increase in health and financial risk for fishermen. So in our analysis and conclusion is that although increased safety trainings and injury prevention from equipment are very important for reducing vessel disasters and should continue, the oral history records point towards a more nuanced need, suggesting a greater emphasis on the outer layers of the social ecology. So looking at economic regulation. But more research is really needed with this population to analyze specific injury and illness questions related to political economic factors and how social movements can influence injury and illness prevention. So we really want to take a research approach that takes structural and social aspects into account, and that is community-based and driven by the fishermen, which really takes long-term trust and rapport building. Therefore, really looking at research to policy and research to practice projects that move towards a community-based participatory research model, which includes a constant comparison between research findings and community needs and desires. So I just want to thank the Southwest Ag Center for their funding of this project, as well as Molly Graham and NOAA for giving us access to the oral histories. If you would like to read more, we recently published this in Marine Policy, and I'm happy to take any questions.
Hello, everyone. My name is Kimberly Prado, and I am a postdoc at UT Austin. I'm an epidemiologist and a promotora as well. I will today present on my pilot project, Texas Ag Worker Cardiovascular Disease Perception, Risk, and Health-Seeking Behavior. Thank you for your attention. My objective was to address gaps in CVD research and disparities in health awareness and treatment among ag workers, and with a total worker health emphasis, which helps us move beyond concentrating on work safety and protection to recognizing social determinants of health among agricultural workers. Other goals included to reduce the risk of work-related illness, increase surveillance, and reduce the risk of illness and injury in this vulnerable population. For CVD, we wanted to understand mechanisms, risk factors, and develop and evaluate possible workplace interventions for cardiovascular disease among ag workers. These are essential workers. Total Texas ag sales in 2017 were 25 million, with 56,000 farms hiring ag workers. And at any given time in Texas, there's roughly 360,000 migrant and seasonal agricultural workers. This is significant because cardiovascular disease is the leading cause of death among Hispanics, the majority of ag workers, with risk factors including hypertension, diabetes, obesity, and smoking. And these factors increase the risk of ag workers suffering cardiovascular disease fatalities because of occupational hazards like COVID-19, heat-related illness, pesticide exposure. Other risk factors that they have include poor diet, food insecurity, low food literacy. And research has shown that cardiovascular disease incidence does increase among workers in a hostile organization. And all of these factors combine and intersect for ag workers to have worse cardiovascular disease health outcomes. Also, risk factors have been seen to change based on sex and migrant seasonal working status. But we do have effective diabetes and CVD risk screening tools provided by community health workers among agricultural workers. Now, my methods included a mixed method sequential exploratory design, a community-based participatory research approach with a community advisory board, including focus groups and surveys, and utilizing a workplace invention called Pasos Saludables. So now our research is a community-based approach, inviting employers, stakeholders, advocates, workers, and community health workers to have input. And we're using a community-engaged, non-invasive, low-cost screening tool. Again, our approach included focus groups, surveys, and with that, we tracked those who rated moderate to high risk for cardiovascular disease, and we tracked them to see if they sought care, if they sought to receive health education, and we used interviews to investigate their motivations and behaviors. Partners on this project were from North Texas, South Texas, and West Texas. These partners helped us recruit farm workers for focus groups, for surveys, and gave input on research strategy and dissemination, and continuing to work with us until the completion of the study. And focus group topics included general health literacy, questionnaires, vignettes to help them share cases, heart healthy habit barriers and behaviors for parent and children, and clinic experiences and habits and recommendations for the workplace and community. Under general health literacy, we found that farm workers had a great desire to learn through outreach. Vignettes helped them share cases of diabetes, lupus, cardiovascular disease fatalities, food insecurity, and testimonies of how they try to take care of themselves to keep working to survive. So, cuidándose para poder vivir. This included heart healthy habits. And heart healthy habit barriers and behaviors for parents, some of them included that there were no convenient options for securing affordable and healthy foods. In the workplace, there were no lunch breaks for them to eat. In the family, for example, mothers had little support for them when they were rearing the children, keeping the house up, or earning a check for the family. For children in the community, the neighborhoods were dangerous and violent. They didn't feel comfortable going out to play, or they didn't have the options to get healthy foods. And limited family earnings provided processed ingredients, excess sugar foods, and salty foods for children. Clinic experiences and habits revealed severe maternal service disparities when in labor, as well as discrimination based in low-income patients, such as asking for insurance or withholding care because they were low income. Recommendations in the workplace community also showed that they wanted convenient, low-cost resources. And for the survey, the topics that we are going to cover are diabetes, cardiovascular disease, and the NIOSH well-being questionnaire items, and that we'll share later as the study continues to develop. Now, the health resource we used was Pasos Saludables, which emphasized 5 points of moving, drinking water, consuming fruits and vegetables, and measuring yourself and sharing your progress. So this was the foundation of what we could offer for health education. And for dissemination, we have an infographic prepared, policy brief prepared. We're developing a cuento to turn it into a radio novela, and drafting manuscripts for publication. Now, moving beyond this, we look to further apply what we learned by joining forces between employers and community health workers for cooperative provision of health knowledge among this population. And we also plan to apply for continued extramural funding to increase the reach of these efforts. Thank you for your time.
Good morning. I'm Dr. Luann Racher, an associate professor at the University of Arkansas for Medical Sciences. My project is titled Occupational Exposure to Aerosolized HPV, Assessing and Addressing Perceptions and Barriers to Vaccination of At-Risk Healthcare Workers. The human papillomavirus, or HPV, is highly associated with anogenital and oropharyngeal cancers. The primary mode of transmission is sexual contact, but aerosolized particles have demonstrated infectious potential in animal studies. A multi-dose vaccine was approved for prevention of HPV-related anogenital cancers in 2006. It has been shown to be over 97% effective in preventing cervical and vulvar dysplasia. In 2020, the ASCCP issued a statement that healthcare workers at risk of exposure to aerosolized HPV particles should receive this vaccine, yet uptake of this recommendation has been slow. The aims of this project were to assess the vaccination status of at-risk healthcare workers, identify barriers to vaccination, and illuminate common misconceptions surrounding the HPV vaccine. We recruited 38 physicians, nurses, advanced practice nurses, and surgical technicians who were at risk of occupational HPV exposure into 6 focus groups. Participants were anonymous. Their answers were recorded and analyzed with qualitative methods. Participants reported possible exposure in the outpatient clinical setting, the operating room, or both. The majority of participants were physicians. Most participants were female, yet this was expected given the female majority of physicians and nurses in gynecology. 1/3 of the participants received the HPV vaccine as part of their routine childhood immunization schedule, and 1/3 were unvaccinated. Less than 12% had elected to undergo HPV vaccination as an adult to protect against workplace exposure. Most participants felt uneducated about the risk of occupational exposure to aerosolized HPV. Some said they did not often think about the risk of exposure to HPV at work. Those who were vaccinated against HPV included the vaccine in their list of personal protective measures, while those who were unvaccinated listed the vaccine lower in their ranking of protective measures. Many felt the odor of surgical smoke was a sign of exposure to aerosolized HPV particles, yet others believed their high filtration masks were able to filter the viral particles even if they could still smell surgical smoke. A few expressed concern about exposure to aerosolized HPV even when they could not see or smell the surgical plume. Participants reported that they were most worried about head and neck cancer. Some expressed worry about warts, nodules, or growths in the nose or throat. A few also expressed concern that they may pass HPV on to someone else. Only a very few participants felt confident in their knowledge of HPV exposure risk, and none reported formal training on workplace exposure or protective measures. Most felt their education came from on-the-job training and following the lead of other coworkers. The 2 most commonly reported barriers to receiving the vaccine included cost and age limits. No one was sure if the age guidelines for administration of the HPV vaccine to prevent sexual transmission applied to the recommendation for protection against occupational exposure. Inconvenience of multiple visits for a 3-dose vaccine series were also noted. Some participants concluded that the vaccine could add an extra layer of protection in addition to their usual PPE. Most unvaccinated participants expressed interest in getting the HPV vaccine, and some vaccinated participants reported they would consider revaccination if it was recommended. Many participants reported their own medical training as the source of information regarding the safety and efficacy of vaccines, yet recognized that non-medical members of the public relied more heavily on media, peers, and family over the opinions of their personal physicians or national guidelines. Most participants had few to no reservations regarding the safety of the HPV vaccine, yet reported public misconceptions were propagated by social media. They also reported the public distrust in the COVID-19 vaccine recommendations may impact uptake of other vaccines in the future. Recommendations for how to increase uptake of the HPV vaccine for at-risk healthcare workers included holding no-cost workplace vaccine clinics for current employees, offer no-cost vaccination at the time of employment for new hires, and provide formal education about the risk of occupational exposure with CME or CEU credit. Thank you to the Southwest Center for Occupation and Environmental Health, the University of Texas Health Science Center at Houston School of Public Health, my entire research team, and all focus group participants.
Okay, so that concludes this session. We have enough time to take some questions for our PIs. And Dr. Patel, I'm not sure if Kimberly Parado was able to join.
Yeah, I don't see her here, so maybe we
Okay.
can redirect her questions directly to
Yeah,
her.
sure. If somebody would make note of her questions. And how do I guess there's a chat box somewhere. There it is. Okay, so
Do you have access to it?
Yeah, I do.
Okay, great.
It's a tiny little box. Okay, so let's see. First question, are there demographic differences? Oh, I think this might have been for the other. Well, no.
Yeah, there's a question from Brett.
That was earlier. Okay. All right, I see it. So for the first presentation, the decreased shrimp population was attributed to increased pollution. I did not see overfishing was listed or the effects of climate change. Do you see the need to increase education on these other factors to shrimpers in order to understand some of these factors and help to shape policy that improves fishing?
Thanks for that question. Yeah, so our results were only looking at what the fishermen themselves said they saw as the issues. And so they did not mention that. There was overfishing mentioned once. It was from an older shrimper who said he got mad about it when he was younger. And now that he's older, he was mad that, oftentimes they had to close the waters. As he got older, he understood now that overfishing was definitely, a cause to some of their issues as well. So for me, with the CBPR approach, I think the whole point is to then it's less about me educating a fisherman and more about them educating me about what they see as the bigger issues, and then being able to kind of slowly translate that, in different ways. And so as one example, we have another project with the Southwest Ag Center on slips, trips, and falls. And when we ask the fishermen, most of them don't want to talk about slips, trips, and falls. They want to talk about the fact that they don't have primary health care. So what we've been doing is working with them on getting them primary health care as a way to then be able to address slips, trips, and falls as a secondary way to do that. So I think probably similar to what you're saying, listening to them, helping them, address the issues that they see as most important first, and then being able to build that trust and rapport to then say, hey, I know you were, protesting that the waters were closing, but can we talk about that, in some different ways?
Thank you. Thanks for that response. This is one about vaccines. So do you think characterizing HPV as a different type of vaccine might improve uptake even among healthcare workers?
Hi, yeah, thanks for that question. I think one of the very interesting things that came out of this focus group is that we really had none of our participants that were resistant to thinking about getting that HPV vaccine if they had not already received it. So I think, yes, when it comes to thinking about promoting the HPV vaccine as a cancer prevention vaccine, and it's totally unique in its design, that for the public, I think it is important to kind of promote that as an unusual and a different type of vaccine, and that it's preventing cancer. But for healthcare workers, they seem to really grasp that concept and really not have, concerns about getting the vaccine themselves. It really was more lack of education in their risk of exposure, and also not knowing that it had been recommended 2 years ago as a preventative measure for a protection against workplace exposure.
Thank you. This is a really fascinating pilot project. Let's see. So, Dr. Guillot Wright, can you speak to strategies for building trust in hard-to-reach populations and how that impacts future research and outreach? Excuse me.
Yeah, so the study that I presented on was a secondary data analysis. So unfortunately, there was no trust building with that one, although I did get to be friends with Noah a little bit better. But for our other work, our strategies for building trust has really been going out to the docks and sitting with shrimpers and getting to know them. And we, have our academy fold-out chairs that we bring out there, a table, and for our qualitative research project that we did, we were looking to get 30 interviews of shrimpers, and that was kind of slow going at first, and by the end of it, it definitely picked up because we had built that trust with them. One story I like to tell about that project is at the very end of it, we were kind of packing up to go, and a shrimper that we had never even seen at the docks walked up to us, and we were spending, we calculated our hours. I think, we've got like close to 100 hours of just being at the docks. And so we kind of got to know most of the people who were coming in and out. And he walked up and he said, hey, I'll be interviewed now. I've been watching you all and I trust you. And so this was, a good reminder to us that oftentimes people are watching us even when we don't think they are. And he had been out there almost the whole time and decided to go ahead and move forward with the interview. And so that's, for us, that was a big piece of it. And then how it impacts future research and outreach is that we now are able to work with these men in a completely different way than if we had just gone out there and gotten an interview and left. I think they understand that we're very much part of the community. We want to, help them move forward their ideas and what they see as, their own health disparities or inequities. And so we've been working with them to do that.
Excellent. So related to that, Dr. Guillot Wright, regarding primary health care for commercial fishermen, is there a high burden of hypertension? And are Gulf commercial fishermen able to access hypertension management resources locally?
Yeah, so there is a high burden of that. So what we have done, most of the fishermen that we worked with did not have any type of health insurance. Actually, I want to say maybe all of them did not have health insurance. And what we did was based on, again, what they asked for, is that we ended up doing what was going to be a one-day clinic out there. We had different, physicians and nurses and community groups, social service agencies out at the docks providing care to them. And that was so successful that we've actually implemented it once a month now. And so the fishermen are getting access to that. If they do have a larger issue, and we have a really great partnership with our local FQHC, St. Vincent's House. They come out, their social worker comes out every month with us and can transport them to the clinic if they need, more management, if they need to get medication. The St. Vincent Center, because they've been coming out every month, actually now understands the unique nature of fishermen. And so instead of saying, okay, here's a 1 week supply of medication, realizing that they need probably a month to 2 months supply of medication because they're going to be out. And so they've been really great about working with us on that.
Excellent. Thank you so much. Back to Dr. Ratcher. I'm sorry, I think I'm mispronouncing that.
It's okay. It's Rachel. That's fine.
Rachel. Okay. Do you think the anti-vaccine movement contributes to reduced uptake of HPV vaccine?
Yeah, so I think we have, since it's a unique population, we're really looking at healthcare workers. I think we're a little bit more resistant to falling susceptible to that anti-vaccine movement. Of course, that's not universal. We do have some doctors and nurses that do, kind of participate in that, but I think they're really more the exception rather than the rule. And we are at a university-based system where evidence-based medicine is really crucial. I think if we get out into the community, which is part of our next steps in future projects, then we may see a little bit more of that. And so the short answer is yes and no. I think, we're a little bit protected in that, we do have a higher degree of health literacy in the healthcare worker population, but everyone is susceptible to, social media and biases and those things too. So we do have some plans on how to overcome that, or at least try to combat that.
Thank you. So I'm curious if any of your promoting HPV vaccine, do you think any of these strategies would translate well into COVID vaccine?
Yeah, and actually we asked, and I put this just briefly in some of the written part, I didn't really say it in my presentation, but we kind of related thoughts about your own personal protection against HPV and how that potentially has changed with the COVID pandemic. And, I think PPE really came into question in the COVID pandemic because we were all of a sudden things that we were using single use, where now we're being told use multiple times because we may not have access to it in the future, or we don't have, access to enough masks or gloves or gowns or whatever that may be. And so our participants did say that, initially before the COVID pandemic, they kind of blindly thought that they were being fully protected against HPV exposure with their high filtration masks and with, the measures that they took. But then as the COVID pandemic kind of changed the way that PPE was utilized and access to PPE was limited, it did start to make them question, have I been blindly trusting something that we've not really had reasons for using this as our way to protect? So I think that the COVID pandemic really kind of changed the way that a lot of us looked at our personal protective equipment, what we are told by administrative level people who are supposed to protect us, and kind of brought some of that into question. And so I think, yes, the vaccination status and the trust in vaccines and in PPE really has been affected by COVID.
Just another one of those things COVID has done for us. This seems a positive, however. So thank you all to the presenters. I think I'm excited about the focus on health promotion here in these three. I think yeah, wonderful work. And thank you so much for taking questions. Dr. Parado is not here, but if anyone has any questions for her, feel free to type in the chat and we will email them to her.
I put a question in the chat. I'd be interested in hearing input from the two presenters that are here, just related to your thoughts about, when you have workers that are not in a position where they feel like they can directly influence policy or directly influence, activities that are taking place that will impact their health and safety. What approaches we might be able to take to try to help empower those workers. I know you talked some about some different grassroots efforts and things like that. So I'd just like to hear your thoughts on how they might be able to more effectively address some of those concerns that they have.
I can go first. So I really think it was very interesting because when we started the focus groups and everyone knew that they were participating in a focus group about HPV exposure at work and perceptions and thoughts about that. And you know, some of my like nursing colleagues and surgical technologist colleagues, they when I would ask, you know, what do you think about HPV exposure at work, they would say, I never really thought about it until I was invited to participate in this focus group. And now that I'm thinking about it, I'm very angry or I'm very frustrated that I feel like maybe I'm not being protected to the highest level that I could be. And why has this vaccine never been offered to me for my workplace exposure? And why has someone never told me that I potentially have the risk of oropharyngeal cancer or even just precancer or even just nodules that could lead to voice changes, like all these things? Why has that never been brought up and never been addressed? But yet I'm getting flu vaccinations every single year, and I'm being forced to make sure that I have my hepatitis B vaccination, or sorry, hepatitis B vaccination before I start work. And you know, and the COVID vaccine being pushed so broadly too. And so they're like, those are great, but those don't cause cancer and don't potentially cause death. I mean, COVID a little bit, but death to the degree that head and neck cancer could. And so I think it really kind of triggered a small uprising, at least a little bit of questioning the system. And I really think it's going to be held to my group now that we have to follow through. And so administration already kind of knows that this is coming. And I think I'm really hopeful that we can make some changes because it is odd that it's not looked at in a similar way, that we're very focused on preventing, you know, hepatitis and HIV exposure, but there's no vaccine for, but all these other things that we do as healthcare workers, we're protected against and promoted against and required to get these vaccines, but yet HPV is not even on the radar.
Yeah, I would agree with everything, and maybe just kind of pick up where at the end of that statement, which was now it's on us to do something. And I think that's a big piece of it. So what we've been trying to do over the past year is really build relationships with some of our local, state, and federal policymakers who are in this space. So federal, looking at people who are working on like H-2A and H-2B visas, and then state, you know, who are kind of the low-hanging fruit, the people that we know are supportive of like healthcare for all and wanting to make sure that, you know, immigrants have, you know, the same rights to healthcare that other people do. And so kind of like a research to policy piece there. So we create policy briefs, we go up to the Hill, and, you know, meet with staffers and try to kind of be available for them. So like, what is it that they need for their legislation? What's the language we can provide? What are stories we can provide? And so it's kind of flip-flopping the lobbyist, right? So instead of saying like, this is what I need from you, you know, finding people who have common interest and saying like, what is it that I can do for you, and putting our research in plain language. And, you know, that's a slow moving process. I think policy is interesting, but it's like a right now thing, while at the same time, it takes years to then push it through. So a staffer might want something within 48 hours, but then that legislation might take 10 years to get passed. So, you know, it's an interesting space to work in, but I would agree that it's, you know, at the end of the day, if we're asking people to tell us their stories and to, you know, help us move research and evidence forward, we need to also show up for them and make sure that we're moving what they need forward.
Thank you so much. So quickly, one last question, Dr. Racher. The focus group results you shared are so essential in future prevention for healthcare workers, very exciting data. Can you comment on next steps? You may.
Yeah, I sure can. So we're looking for some more funding. The next step would be that I want to create an educational environment, like an interactive educational model that will provide CME or CEU credit for the participants. So all healthcare employees are required to maintain continuing medical education in some kind of fashion. So we want to design that project, and then in conjunction with that, then offer HPV clinics at my vaccine clinics at my university. I think we start at home and then expand it broadly from there. And so I think if we can show that the educational piece combined with the local like we come to you type vaccine clinic, just like we do for flu clinics at work, then if we show that it works and it gets people vaccinated, then we can take that out into the community programs also and really promote that as well. And you know, at no cost to the employee, it really should be included in their workplace risk package.
Can I say something real fast? I don't want to give the wrong idea on something, sorry. When I said low-hanging fruit and policymakers with the immigration, I think that's a very specific example because of Texas and sometimes the history of immigration. But I actually did a study with federal policymakers, and it was almost like even between Republicans and Democrats and independents on them wanting, like the staffers wanting research evidence and wanting researchers to engage them. So just wanted to throw that out there too, that if you want to engage in policy, you don't just have to like go with, you know, one particular party. That generally speaking, most of the staffers who are working on these issues are kind of hungry for evidence.
Thank you so much. I actually agree with that statement, just based on the educating and informing the Ag Center does. Sometimes we just get thrown into a whole other direction because they are so hungry for information about something that is, you know, might be remotely related, but agree with that statement completely. Okay, well, thank you all so much. I learned a lot. I hope everyone else did too. So it's 10:02. I'm not keeping the clock. So
taking a very quick break.
Keeping time. Okay, so back at 10:05.
All right. Well, thanks again, everyone, for joining us, and really appreciated the first section of presentations that we had. We'll be entering into our second section here. Following the same format, we have 3 presentations that were pre-recorded. So we will watch each of those presentations, and then we'll have a time for Q&A discussion with the PIs that worked on these projects. And throughout the presentations, if you would go ahead and enter any questions you might have or comments into the chat box, and then we will discuss those at the end. So these 3 presentations are related to ergonomics and workplace hazards. We have a presentation from Casey Aguiar at Texas A&M Health Science Center, from Mark Wilson at Tulane University, and from Daisy Rosero from the University of New Mexico. So Sylvia, if you can go ahead and cue those up, we will watch those together and then have time for Q&A.
Good morning. Today I'll be sharing findings from a follow-up study that was conducted in 2019. This current research examined how a period of remote work affected musculoskeletal discomfort, physical activity, and computer use in a sample of traditional office workers who became remote workers during the COVID-19 pandemic. The issue we're ultimately trying to affect is the occurrence of musculoskeletal disorders. They are costly and common, which is not surprising. This discomfort can occur after just 2 hours of sitting, and this is not good news for the sedentary office worker population, which can sit for upwards of 15 hours per day. Now, there is a good amount of research on traditional office workers, but not so much on remote office workers. There was little research on this population before the pandemic, and even now, most of the remote worker studies focus on what happened to people during the mass lockdowns in 2020. We just don't have much data on how this period of remote work affected office workers now that they have had time to adjust to a new normal. In 2019, one of our studies aimed to see if physical activity, computer use metrics, and musculoskeletal discomfort differed based on what type of desk office workers used. The study provided the baseline data that we are using in this follow-up, allowing us to compare these metrics before and after a year of remote work. This current study, conducted in the fall of 2021, recruited participants from the same pool that completed the original study. This time, the research questions were focused on whether or not musculoskeletal discomfort, physical activity levels, or computer use metrics changed after a prolonged period of remote work. This follow-up study is focused on those same variables. Musculoskeletal discomfort could inform our understanding of how remote work relates to ergonomics at home. Changes in physical activity affect a host of health issues related to obesity and sedentary behavior, and computer use metrics are a way to understand if work quality suffered at all from working at home. It was hypothesized that a period of long-term remote work would create musculoskeletal discomfort due to potentially improper workspace setups at home. It was hypothesized that physical activity levels would be reduced since there could be less time spent walking in an office space. And it was hypothesized that computer use metrics would decrease as a result of non-ideal workspace setups. The study was conducted in the same style as the original. Recruitment was ongoing throughout the semester, and participants were scheduled for 2-week study periods as they had time. During this period, they provided data through 4 study instruments, and data analysis for these instruments was completed this past spring. A study questionnaire was administered at the beginning of the 2-week study period to obtain information like the remote workspace setup, office accessories they used, or caregiving responsibilities they had. They also had RSI Guard software added to their work computer. The software tracked computer use metrics like key clicks or double mouse clicks. During these 2 weeks, participants also wore a Fitbit Charge 4 fitness tracker to monitor their step count. This is the only instrument that was changed from the original study when active file sensors were used. Those sensors were difficult to use and disliked by participants. The Nordic Musculoskeletal Questionnaire was administered at the end of the 2-week study period to collect data on discomfort in different body regions. For data analysis, descriptive statistics were calculated for all instruments. Additionally, a paired t-test was used to compare step count and RSI Guard metrics between 2019 and 2021. McNemar's test was used to compare Nordic musculoskeletal discomfort scores between 2019 and 2021. Of the 64 individuals who participated in 2019, several could not be contacted in 2021. So 53 individuals were contacted for recruitment. Multiple reminder emails were sent, and ultimately 16 individuals agreed to participate. Self-reported information on office furniture use showed that in 2021, more participants reported having used a sit-stand workstation, and more participants had footrests, monitor arms, and keyboard trays at their workstations. The same amount reported having anti-fatigue mats and currently using a stand-biased workstation. For RSI Guard software, 14 variables were analyzed for 14 participants, since 2 could not download the software. The paired t-test showed no statistically significant difference in these variables except for right mouse clicks. Overall, it appears that computer use remains stable after prolonged remote work. For the Nordic Musculoskeletal Questionnaire, the results of the McNemar's test showed that the change in self-reported discomfort between 2019 and 2021 was statistically insignificant for all body regions except the decrease in discomfort in the wrist and hands region. Three participants were removed from step count analysis due to missing active file data from 2019, and 1 was removed due to missing Fitbit Charge 4 data from 2021. A paired t-test was run on 12 participants' data, and it was found that there was no statistically significant mean difference in step count after a period of prolonged remote work. Overall, the results suggest that computer use metrics, physical activity levels, and musculoskeletal discomfort were largely unaffected by a period of prolonged remote work. Even after working remotely for a year, once they returned to the office, individuals returned to pre-pandemic levels of productivity, activity, and comfort. Despite efforts to increase participation, the sample size remained too small to reliably draw conclusions from the results. Also, there could be seasonal effects in the results since the original study was conducted in spring and the follow-up was conducted in the fall. Finally, other effects like health issues or aging could have played a role in the results. The field does not have a lot of follow-up studies in its literature, and the study provides a follow-up of musculoskeletal discomfort in office workers. Additionally, it shows how office workers are performing after a period of crisis and not just during the worst of the pandemic. Finally, I would like to thank and acknowledge the Southwest Center for Occupational and Environmental Health, the Ergo Center at Texas A&M School of Public Health, and Dr. Zogi from Texas A&M's College of Engineering for the financial support and research guidance that made this work possible. Thank you very much.
My name is Mark Wilson, and I'll be discussing my pilot project, Physiological and Psychological Impacts of Fabric Face Coverings, an assessment of real and perceived heat stress, cardiovascular load, and work rate. So this is a brief outline of the presentation. We'll go over background, study design, data collection and analysis, and discuss some conclusions and limitations. But overall, this is a demonstration of using wearable sensors to detect heat stress outcomes. So thermal stress is associated with a significant physical agent exposure in many occupational environments. We're homeothermic organisms, so it's critical that we maintain our body temperatures within a narrow range of conditions. We can model changes in our core body temperature based on what we are doing physically and the environment in which we are doing that activity in terms of heat or cold. The ACGIH TLV for heat stress incorporates both of these concepts in terms of metabolic load as well as environmental conditions, but additionally has a clothing adjustment factor, which accounts for what we're wearing. So the question we're asking is, do fabric face coverings impact heat strain endpoints? And we're using wearable sensors, survey instruments, and work output as response variables over a 30-minute exercise task period in elevated and ambient conditions. So people use a pedal exerciser with and without face coverings in elevated and ambient conditions, and wearable sensors give us telemetry data on core body temperature and heart rate in real time. Study subjects are surveyed using a validated perception of effort survey scale to determine differences in perceived effort for the exercise task based on the conditions, and work output was recorded from the exercise equipment based on distance traveled, calories burned in each of the experimental conditions. The heat strain data analysis was accomplished by exporting a .fit file from the Garmin smart device, which is then cracked open using open source software Golden Cheetah and then fed into R for further analysis. A physiological strain index, which was first reported in 1998, was calculated using these data. So the initial experiments used rectal temperature readings, and we are using a much less invasive methodology. So this is just a visualization that shows single subject strain index calculated over the exercise period, comparing both environmental and mass conditions. And note that we can also break that experimental period down into component tasks, so we can evaluate whether or not specific tasks are associated with increased risk. So there was no statistically significant difference associated with mask use and strain index. The relative perceived effort showed that people do perceive working harder when they're wearing face masks. So in both elevated and ambient conditions, the perception of effort is elevated, and there were no statistically significant differences in work output as it relates to calorie output or distance traveled on the pedal exerciser, regardless of mask or environmental conditions. So in summary, our physiological data showed us that we had no significant differences in strain index, Perception of effort appears to be increased with mask use, and there are no determinable differences associated with work output. Some significant limitations, though, are that 85 degrees Fahrenheit, significantly lower than real-world temperatures. The study design is just for short-term evaluation, so can't be extrapolated to an 8-hour TLV, and it was self-paced. So these are our products associated with our study. It's a foundational data set that demonstrates the concept, and we've generated an analysis pipeline which allows us to have granular data associated with individual effects for heat stress. Next steps include comparisons of where the sensors are worn on the body and having a master's student project focused on cross-sectional analysis of the.
This presentation is reporting on the impact of COVID-19 on organic farmers, results of a national study of USDA certified organic farmers. 62% of certified organic operations worldwide are located in the U.S. Most are small farms producing fresh foods. Demand has been steadily rising and products are widely available. COVID-19 affected food availability, industry practices, and consumer behavior. At the height of the pandemic, sales increased almost twice as fast than the previous year. And when the U.S. lost 22 million jobs between January and April 2020, farmers were impacted. But despite limitations, farming, an essential service, remained active. However, to comply with CDC recommendations, producers reduced their workforce and implemented prevention practices. Workers reported reluctance to test for COVID-19 for fear of losing their jobs, and mixed messages hindered prevention efforts. There's also evidence that the pandemic intensified flaws in our healthcare system. The study aimed to gather data on demographics, behavior, prevalence, and healthcare delays to examine levels of risk and understand factors that may influence decision-making. Only a snapshot of data exists for this population, but this body of knowledge is growing. The National Organic Farmer COVID-19 Survey is a theoretically informed cross-sectional survey developed with expert input. We conducted descriptive correlation and regression analyses using SPSS 25 and calculated Cronbach's alpha for a 6-item prevention scale. Table 1 is a summary of reported demographic characteristics. Some characteristics are consistent with existing surveillance systems: place of birth, race, sex, farm size, and age. Education level has not been collected elsewhere. Over 1/3 of respondents experienced non-COVID-related delays in healthcare. Overall, COVID-19 prevalence was 9.6%. Overall prevalence for producers alone was 6.4%. Prevalence on only 2 demographic characteristics were statistically significant. Higher infection rates were reported by those with less than 4 years of college education and those with larger farms. Cronbach's alpha indicates a high level of consistency among the 6 prevention methods. Of the 6, respondents did best following the 3 most highly publicized prevention methods. Correlations were observed between following prevention methods and several demographic characteristics. In the regression model, when controlling for farm size, only sex and farm size were statistically significant. When examining the odds of experiencing non-COVID-related healthcare delays, being female was the only significant demographic characteristic. In Table 9, women who were married or cohabitating had greater odds of experiencing non-COVID-related healthcare delays. This study generated much-needed data and provided valuable information that may be essential for allocation of resources, injury prevention, health education, and policy aimed at supporting and promoting organic agriculture. Self-reported confirmed cases among organic producers in this study was lower than that reported among agricultural producers and farm workers in other studies. Overall, household prevalence of COVID-19 was consistent with infection rates observed nationally. Variation in prevalence estimates suggest the need for more research in this area. Correlations between the frequency of following prevention methods and COVID-19 prevalence suggest that mask wearing was a measure of prevention. Although there were significant relationships between the frequency of following prevention behavior and demographic characteristics in the correlation and regression analyses, those with greater significance, gender, race, and farm size, should be examined further. Mixed messaging and contextual factors, including work environment and socio-political discourse, may have contributed to individual perception and resistance to practices. Further studies should include questions about vaccine hesitancy. Although the real impact of the pandemic on morbidity and mortality is still unknown, a high percentage of participants in this study reported experiencing disruptions in healthcare services. Of relevance is that female producers and those who were married or cohabitating were more likely to report non-COVID-19 related healthcare delays. Organic producers reported high compliance with 3 of the most highly publicized practices: social distancing, wearing a face covering, and avoiding contact. This study collected national data on healthcare delays among organic producers and identified sex differences in non-COVID-19 related healthcare delays. While the results of the study are consistent with emergent literature of the impact of the COVID-19 pandemic on healthcare utilization, this study is the first to collect information on prevalence and prevention behavior of organic producers and can serve as a baseline for future studies. Future studies should center on understanding the circumstances that impact and influence organic farmers' prevention behavior. This information is essential for the allocation of resources, health education, and policy aimed at ensuring appropriate food supply and supporting organic farmers. Thank you for your time and attention. This work was made possible by a grant from the Southwest Center for Agricultural Health, Injury Prevention, and Education. References are available upon request.
All right, great. Thank you, everyone. Encourage our panelists that were part of those 3 presentations to go ahead and enable their video and get prepared for our Q&A time. Again, if you have questions you'd like to add to the chat, please do so. I'll be monitoring that and trying to help moderate the questions we have for our presenters. It's interesting. I mean, it's a fact of life that we've been living with the pandemic for the last couple of years, and each of these presentations sort of touched on some issues related to pandemic-related measures or pandemic-related issues in the workplace relating to safety and health. And so I think we'll have some interesting application of this in the years to follow, and some good opportunities to have our discussion today. So just to start off, Dr. Wilson, it did sound like your presentation was cut a little short there at the end, and there was a request for you to elaborate a little bit on your next steps for the project.
Okay. I don't know exactly where it cut off. I don't like listening to myself. So that's kind of germane to what we're talking about with remote work. One of those things that stresses people out. So I don't know if I can share my screen or not, but I can just go through the bullet points that are on the slide. Currently, the way that I was doing this, we were using a chest-worn heart rate monitor, and sometimes it works really well, and sometimes it doesn't work really well. And it really seems to be associated with BMI. Kind of large people don't give real good readings, but the wrist worn heart rate monitor in the Garmin device usually worked pretty well. But I don't have pairwise data to make a comparison to calibrate one against the other. So that was one of the steps that I was going to do. And I also have a fair amount of cross-sectional data in terms of demographics, underlying health status, type of mask, etc., for each one of the currently 17 subjects. So we're still running it. And I'm going to have one of the master's students in the industrial hygiene program evaluate the cross-sectional data for the various response variables. And then we're going to do hopefully a little bit of field testing in heat strain monitoring in food truck workers.
Yeah, that's great. Thank you. I'm interested in hearing about the food truck workers a little bit, if you can elaborate on that and how you're going to set them up for measurement and what your plans are there.
I'm going to put sensors on them and then get the data.
That's a pretty vigorous, I mean, from what I've seen of food truck workers, you know, really hot, very active, and you know, over a pretty long period of time. So was that your initial goal in this work that you were doing with some of your calibration, how to work with the sensors and technology and analysis side of things?
No, it was initially that, you know, the COVID pandemic made everybody wear face masks, and I would exercise wearing a face mask and didn't like it. And, you know, really wanted to see if there was any discernible difference associated with plus or minus face coverings in hot environments, which there weren't. Short term.
Yeah, what was your what are your thoughts from a worker point of view? And this relates to one of the questions about acclimation, acclimatization to you know, working in the heat with a mask on, different mask types, these kinds of things.
So I'm in New Orleans and it's hot. So pretty much everybody and all of my study subjects were New Orleanians. So pretty much everybody is acclimated to heat anyway. But the study design was just one day of exercise in an ambient environment and one day in an elevated environment, and randomly assigned to which one you started in. And, you know, you completed a exercise task up to 15 minutes and either put on or took off your face mask for the remaining 15 minutes. So pretty.
Well, I have to agree. At least my own personal experience has been, you know, there is at least a little bit of a mental perception of being hotter and of it being a little more challenging to breathe. But I know the studies don't support that I've seen. So it's good to see your data as well.
But I would caveat that with this is really short term, and time definitely makes a difference. So that was the only statistically significant variable in the study, was the duration. The longer that you were in a hot environment, whether you were wearing a face mask or not, you had an elevated strain index. But, you know, getting people to exercise in a hot environment for 30 minutes and paying them $10 is difficult enough. So I couldn't really get a realistic assessment of what, you know, an 8-hour TWA would be. And I think that's really important to look at because it may reflect reality, because there's, you know, a high likelihood that we'll go back to masking at some point. So.
Well, maybe some of your food truck work will wind up with some workers that are having to mask and some that aren't having to mask, just based on what's happening during the next 6 to 12 months. So good luck to you in that. A question for Dr. Aguiar on the workplace ergonomics study. What plans do you have to compare traditional office work versus work from home versus hybrid models?
I was looking at that. First of all, not a doctor yet. Hopefully this December when I graduate. But I was looking at Michael's comment about what plans there are to compare this versus work from home hybrid models, or having open workstations, or not having consistent workstation use. I don't know if anyone's going to continue the research that I specifically did for this follow-up study, but I know that even now for my dissertation research, and even now with the work that our Ergo Center is doing, that's definitely a big variable that we're looking at. Like, how many hours are they working in a traditional office versus at home? What do those different spaces look like? What equipment do they have in each? Is it like a consistent workspace, or is it a moving like more flexible workstation. So I think just going forward, we're a lot more attentive to that variable, and we're looking at different details for what that could look like. I don't think we have like a specific research plan for specifically looking at that, but I think at anything we do moving forward, we're going to be looking at that, asking questions about it, or even getting photos. Yeah.
And Casey, when you did your study, were you looking at people who had transitioned back to the office again, or were some of the people that you were studying still in a work from home environment? And do you think that would influence the results that you measured, looking at workers who were still working from home versus those who were in the office environment?
Definitely had a big effect. I wish that the sample size was a lot larger so that those effects could be more significant. But when I first started putting together the study, everyone in the cohort should have still been working from home. And right at the summer, right about at the point where we started the study, everyone started to come back to the office. And so that was a bit of a bummer, but I do see that there is still value in seeing how things were carried over from working from home versus being back in the office, where there's still any effects that lingered there. And we saw that there really weren't any. Granted, of course, the study sample was a lot smaller than I hoped it would be. But I definitely think there was a difference there, that they weren't working just from home anymore. They had started to transition back.
Did you have any questionnaires that asked about their workplace environment? You know, did they have an office chair? Were they working at the kitchen table? Those kinds of things.
Yeah, I did have questions that asked about what spaces they worked in. It seemed like a lot of people did have an office space, but also a fair amount of people were still working at a kitchen table or somewhere a little less official. We also had questions about what kind of office accessories they had. And so we had questions on that from the original study and from the follow-up. And it really looked like nobody had regressed in terms of the type of office equipment they had. If anything, they kept like their footstools or their standing desks, and maybe they added more things, like they got a better keyboard, or they added a footstool, or they got a standing desk or a better chair. So it seemed like people were at least progressing in terms of the things that they had at home.
One of the memories I really have from early in the pandemic is all the pictures of people trying to improve the ergonomics of their workspace that they had at home, and lots of, boxes stacked on top of tables and different things like that. So that's an interesting part of the investigation, is looking at how they're adjusting to their work environment in this sort of hybrid space.
Yeah, that was the thing we asked about too, was if they got education or training from their workplace or if they sought it out by themselves. And I noticed that it seemed like if people didn't get that training from their workplace, they were more likely to say that they had sought it out on their own. So I'm hopeful that this whole pandemic has sparked more of an interest in office ergonomics for the normal worker, and that will translate to helping us in research and health outcomes in the future.
Right, that's great, thank you. Daisy, I've got a question here asking about, in your study, what your thoughts are on what might explain women, particularly women with significant others, to have more significant non-COVID healthcare delays.
Yeah, that's a great question. Thank you for that question. So what we found in some of the existing literature is that women in general have a higher caregiver burden. So they're carrying more of the weight of the family dynamics. And so they may be in some ways neglecting the care that they need for themselves. But at the same time, women tend to access care more often. In other words, they keep scheduled appointments with their PCPs. They go and take care of of themselves on a more regular basis. And so when you have someone utilizing care more often, it just may look like they have they're having more significant differences in accessing, or basically having healthcare delays, because they are trying to access healthcare more often than men are.
And one of the things I'd like you to comment on, if you would, you shared some demographic information, but maybe I didn't have enough time to catch it on the screen due to the presentation style that we're using. I wonder if you could talk a little bit about the demographics or some of the differences that you see in organic farmers versus traditional farmers that you think might be relevant.
Yeah, there was a lot of information to present, so those slides did go fairly quickly. I was trying to get it all in there. So we did find that there were some differences, and there were some new things that we collected. For instance, education level. We didn't find other sources where we had a good handle on the education level of organic farmers. And in that respect, we found that organic farmers are younger, they're more highly educated. In other words, they have a four-year degree or more. And so that was a difference that we found between the conventional farmers and organic farmers. With respect to the other demographics, and there were quite a lot of them, we presented just a very quick snapshot of all of them. The male-female comparison is about the same. We had about 34% female organic farmers, and that's consistent with the national surveys. The race and ethnicity makeup was very similar as well. In our study, we had about, I want to say it was 90%, if I remember correctly, of white, non-Hispanic persons. In terms of ethnicity, I believe we had a little bit of a higher rate of Hispanics who are organic farmers. I mean, there's just a lot of information. I'm happy to share the slides and presentation with others who would like to take a look at that.
And were you looking at farm workers, or were you looking at farm owners? And are there some potential differences there?
Yeah, thank you for that clarification. It gets a little tricky with the language. We were looking specifically at organic producers. We have, there's just a little bit of data out there on conditions for farm workers, especially with respect to COVID-19. And so what we found was that prevalence for farm workers was a lot higher from some of the studies out in California. I think it was 22%. For us, in our study, we had a 6.4% prevalence rate for COVID-19. And then there's a shop out of Purdue University who had a prevalence rate for organic producers at about, I want to say it was 9%. So there's just a little bit of discrepancy in what the prevalence really is for organic farmers.
Did you consider the crops that were being produced and harvested, and what techniques are being used in the process of cultivation and harvesting, and those factors, how that might influence some of this data?
We did not look at the type of crops, but we were looking at farm size. So we did find that farms with that were larger than 50 acres had a higher prevalence of COVID-19 than farms with smaller, less than 50 acres.
All right, thank you. I'm going to hop back over now to Dr. Wilson with a question about your body temperature measurement. One question was, what product were you using for the chest sensor? Were you using the Zephyr or something else? And did you consider some other core body temperature measurement tools? The pill that you swallow was one that was referenced in the question there as well. Maybe a little extreme for an office worker environment, but was wondering what all you considered and what you used.
Yeah, so I used the core body temperature sensor, which is from Green Teg AG, which is a Swiss heat flux sensor manufacturing group. It's a spinoff from the Swiss Institute of Technology. It's widely used in performance monitoring for athletes. The Swiss national cycling team uses it in the Tour de France. They've done a lot of validations already with their algorithm with internalized radiothermometer pills. So the idea behind what I wanted to do is to not do things that were invasive, and to rely on the previous validation studies to kind of justify that approach.
Yeah, it seems like from another study that I've reviewed, there's pretty good correlation in results between the radiothermometer that you can swallow and the external sensors. And it sounds like as long as you're getting a good reading, that was your results as well, that you were getting good data from your sensors.
I mean, I didn't have a way to compare to an internal reading, but the previous data that the organization has is pretty compelling. So,
great, thank you.
Yep.
Casey, if you could comment maybe on the office furniture. The question here was asking about the chair. Did the type of chair factor in as part of your ergonomic study?
Yeah, we specifically didn't ask for type of chair, but I feel like that's going to be an important variable to be looking at in the future too. As part of my dissertation work, I've been looking at all of the furniture-based office interventions for like the past 10 or 20 years. And I see that there aren't a ton of studies that specifically look at chairs. And when they do look at chairs, they don't get very specific as to the type of chair, you know? I feel like as ergonomists or as aspiring ergonomists, like we know what makes a good chair, but I don't see people talk about that a lot in the literature. And as we look more at the workplace, since the workplace is changing, I feel like that's something that we need to focus on, you know, specifically like describing what a good chair is or what good type of furniture is, and actually describing that in our research and looking for it. So we didn't look for that right now, but I really see the need for that in future research.
I think the ability to adjust the work environment appropriately is always important. And the big challenge that we have with work from home is when people don't have access to that equipment. Did you see, you mentioned some information about training that was provided by employers. I know you had a small sample size, but were you able to sort of glean any practices that you thought were particularly effective, or things that you think we should be considering in the future if we have work from home, employees, and how we might need to make sure that we're training them to think about the work environment that they're having and how they're adjusting that?
Yeah, that's a really good question. And that's basically what my dissertation is focusing on. Yeah, so for the question, it was really basic. It was just asking for, did your workplace or did you look for training like pamphlets, online web articles? I just kept it pretty broad just to capture anything. And then it was just basically yes or no questions. I wasn't able to get a lot of details to what kind of training people were looking for or what those sources were like. But we really do see the need to have good training for remote office workers and to make sure it's really engaging and as useful as maybe an in-person training or as the usual thing they might get in the office. So I think that's going to be a really, really important thing in the future, that we're sending people home where they have the opportunity to have a healthier workspace, but might not have the know-how to know what that looks like. So hopefully after my first research, my dissertation is done, I'll get a better idea of what that could look like. But right now we weren't able to glean as much really specific information about where people are looking for their training information or for their education.
And based on your Nordic questionnaire, you saw a significant difference in wrist and hand discomfort, if I remember correctly. And did you see, was that an increase, a decrease? What was the direction of that? And do you have any thoughts on what that might relate to?
It was a slight increase, but because the sample size was so small, of course, I can't specifically attribute that to anything. It could just be that I had older individuals, or maybe an individual who had a specific hand injury got worse. I think it's interesting, but I know that I can't, point to a causal effect here.
Daisy, one of the issues, related to organic farming, of course, is different inputs, different use of avoiding pesticides, these kinds of things. do these kind of behaviors contribute to other workplace related injuries? You know, you're doing maybe more hand hoeing or things like that. Does that contribute to other challenges from an occupational point of view for these workers?
So yes, and thank you for that question, Kevin. That is something that we didn't address in this particular study. So we are in the process of analyzing data from a larger study, which is called the Organic Farmer Safety, Health, and Life Survey. And that's the survey that was initially proposed, through this grant with the Southwest Ag. And when COVID-19 hit, we added the COVID-19 survey to this larger study so that we could capture, it was just about the time when we were rolling out the larger survey where COVID-19 hit. So we added that to the larger study. So we're right now in the process of analyzing the data from the overall survey and also looking to see what comparisons can be made with the COVID-19 results as well. But we do know from existing literature that more mechanical work, bending, hoeing, using, just rakes and just all these handheld materials do have an impact on musculoskeletal concerns for organic farmers, especially those that have small farms. And as we know, about 50%, or actually a little bit more than 50% of organic farms are small family-owned farms. So we expect to see those results in probably the next 2 or 3 months.
It'd be interesting maybe in the future to look at the use of more ergonomic manual tools for doing that work, and what the level of education, knowledge, and use is amongst those organic farmers.
We are, and in fact, one of the things that has come out, one of the products that has come out of this study is a training, a safety training for organic farmers that we're conducting here in New Mexico, and preliminary results from that training indicates that smaller farmers don't actually have enough information or training about proper use of tools, about safety requirements. So we're finding that they're not wearing hats, they're not using the correct equipment to do some of the work that they're doing, the manual labor that they're doing. And so we're looking to improve on how, at least here in New Mexico at this time, doing this pilot survey and this pilot training, to try to tweak what what specific mechanical safety training these farmers may need, those especially that are working on the smaller farms.
Great. Well, thank you, everyone, and really appreciate the presentations again. Great job. Very interesting topics. We are going to take another quick break. So we're scheduled to start back at 10:56. So if you could take about a 4-minute break with us and keep us on schedule, that would be optimum. Thank you, guys.
Thank you.
Okay, so welcome back, everyone. It is an amazing, has been an amazing day so far. We've had some great presentations, especially the keynote, and also the 6 presentations so far by the awardees in the last year. So it's fascinating to see all this great work being done. So I'm here to moderate the third and the final session for today's symposium, and we'll follow a similar format. Feel free to jot down your questions along with when the presentations are going on, and put them in the chat box, and we'll make sure to make them part of the discussion after the presentations. In terms of presentations, we have Dr. Nishita Sinha from Texas A&M Transportation Institute. We have Dr. Itamar Lerner from University of Texas Health Science Center at San Antonio. And then we have Dr. Bethany Alcouder from the National Center for Farm Worker Health. The entire topic, the entire third session is basically related to risk factors for occupational health. So Sylvia, Ms. Santiago, if you can just get the presentation started. Thank you. Sorry, a quick correction. Dr. Idamar Lerner is not from University of Texas Health Science Center at San Antonio, but from UT San Antonio. So quite close, but apologies for the wrong information.
Hello, everyone. I'm Nishita Sinha, affiliated with Texas A&M Transportation Institute. Today, I'm presenting our research on risk perceptions in agricultural aviation. This is a joint work with Eva Ship at TTI, who's also the project mentor, Stephanie Payne at Texas A&M, Tim Strutman at the Ag Center, and Jeff Borowick at TTI. The ag aviation industry aids production through rapid and efficient application of fertilizers without damaging the crop or eroding the essential topsoil. Furthermore, the industry protects forest cover and against diseases caused by mosquitoes, in addition to supporting aerial firefighters. A typical application operation consists of an operator pilot who has the Part 137 certificate that allows them to apply chemicals. An operator pilot is a business owner. The non-operator pilot is employed by operators to fly aircraft. Operators and pilots work together to apply treatments. Much of the benefits from aerial application, however, come from applicators flying at high speed in low altitudes, maneuvering around external objects and carefully minimizing any drift. Pilots face a risk of collision when operating at low altitudes and must be extra attentive when operating their defensive equipments. Available data suggests an overrepresentation of accidents in agricultural aviation. The accident rate in ag aviation is higher than rest of the general aviation. Over the last 7 years, the average share of fatal accidents has gone up by 118% compared to the average in the 7 years preceding 2014. Risk perception is a key aspect of risk management. Biased risk perception can lead to underestimation of actual risks and ultimately erroneous decisions. When operators and non-operators do not perceive hazard similarly, this is likely to result in discrepancies over daily decision-making concerning operation. In this study, we answer if there is a difference in hazard perception of operators and non-operators. The answer is likely to help develop targeted training programs to minimize perception biases. In doing so, we address centers' intermediate goal of supporting evidence-based prevention activities to promote safety. 2 waves of web-based survey of operators and non-operators were conducted in 2011 and 2018 with support from NIIAA and the Ag Center. This study is based on data from the 2 surveys and focuses on risk perception items and select socio-demographic variables. To elicit risk perception, participants were presented with a list of 15 potential hazards and asked to rate each one on a 10-point scale. On the scale, 1 was considered not a risk and 10 was considered extremely risky. They were also provided with examples such as crossing the street without looking and running with scissors. In this slide, I show the list of hazards for which their perception were elicited. These include safety hazards that aviators face while flying the aircraft on a day-to-day basis. 3 of these aircraft short night application and unmanned aircraft systems were only available in the 2018 survey. In the surveys, cumulative work experience was measured along with information on prior encounters with hazards and prior injuries. In the study, we include total ag hours flown as a measure of work experience. Information on prior hazard encounters, although, was not collected in the 2011 survey. In this slide, I present the average risk perception across all 15 items. Perception ratings were highest for power lines, followed by communication towers and meteorological towers. The perception ratings were lowest for cockpit clutter. The ratings also show an increase from the last survey. Here we visit on the comparison of ratings between operators and non-operators. The data here come from the survey conducted in 2011. We can see the non-operators in general have a higher risk perception than operators. Here we evaluate the same comparison but using data from survey conducted in 2018. Consistent with the previous chart, we see again that non-operators rate the hazards riskier than operators. In order to investigate the perception difference, we look at differences in socio-demographic variables between the two groups. We find that the operators are older and have more flying experience. We also find that operators are more likely to report injuries than non-operators. In this slide, I show the correlation estimates between average risk perception and our all independent variables. We find that age and flying hours are negatively correlated with average risk perception. We also find that prior injuries is positively correlated with average risk perception. We run hierarchical regressions to assess if differences in socio-demographic variables can account for differences we observe in risk perceptions. However, we find that differences in perception remain even after we control for age, work experience, prior hazard encounter, and injuries. Moreover, this is true for data coming from both surveys. In conclusion, our study is the first to pinpoint industry hazards perceived riskier than others, in addition to establishing heterogeneity in risk perception within organizational level. So far, we have presented our results at the Ag Safety meeting, and a manuscript is under review. Future research regarding safety in ag aviation could focus on finding factors that are behind the observed divergence and evaluating if the perceptions are in line with actual risk assessment. The results can help devise training programs to ultimately close the gap between perceptions. I want to end by thanking the Ag Center. I'm grateful for this opportunity provided by them as part of the Pilot Feasibility Studies program, and I look forward to their continued support in my journey as a young researcher and beyond. Thank you so much.
Hello, my name is Itamar Lerner, and I'm an assistant professor in the Department of Psychology at the University of Texas at San Antonio. Today, I'm going to present to you a pilot study attempting to examine whether physiological measures of regular day-to-day habitual sleep could predict the degree of stress response we experience following exposure to real-life stressors. The general background to the following study is the attempt to understand post-traumatic stress disorder, or PTSD. PTSD is a mental condition that can sometimes appear after people experience a severe traumatic event, for example, life-threatening combat, rape, and so on. Its symptoms include recurrent memories of the trauma, flashbacks, avoidance of trauma reminders, and so on, that persist for more than a month. Sleep disorders are also very common to PTSD, and there is a growing understanding that abnormal sleep after the traumatic experience may not only be a symptom of the disorder, but also contribute to its initiation. However, much less studied is the possibility that some sort of sleep deficiencies have already existed in those people who are prone to develop PTSD. In other words, it is not just the quality of sleep after the trauma, but the quality of day-to-day habitual sleep before the trauma that might matter. Existing literature that did examine this question suggests that this indeed might be the case. Sleep deficiencies may tend to pre-exist in people that develop PTSD after a traumatic event. There are two types of studies examining this question. First, field survey studies in people with PTSD, especially military personnel, who self-report the quality of sleep before experiencing trauma. Those studies suggest that indeed factors like sleep duration, insomnia, and existence of nightmares before the trauma could all suggest higher probability of developing PTSD after experiencing a traumatic event. Another type of studies examine the effects of sleep on PTSD in the lab through paradigms like fear conditioning, which model real traumatic experiences using small-scale stressful stimuli that subjects are exposed to, like a mild electric shock. In those studies, physiological responses of the body to the shock, including autonomic system responses and brain activation, can be measured, as well as physiological sleep measures, such as the amount of time spent in different sleep stages. Prior lab studies examining how habitual sleep affect physiological measures during conditioning have found that a particular sleep stage, rapid eye movement sleep or REM sleep, can predict the physiological responses to fear, including brain activation in relevant areas. Specifically, higher percentage of habitual REM sleep out of the total time spent in sleep predicted smaller stress responses and lower activity in fear-encoding circuits in the brain. In other words, it seems like habitual REM sleep serves as a protectant from excessive stress response during exposure to fearful experiences. All in all, field survey studies show that low quality of sleep before trauma, based on subjective sleep assessments, may increase PTSD likelihood after trauma. But they don't say anything about particular sleep physiology that contributes to this phenomenon. Lab studies with humans and animals, on the other hand, show that low degree of REM sleep before fear conditioning predicts stronger brain and body responses during fear conditioning. But they're not directly testing people with PTSD, only a lab model of PTSD. A question then rises: does poor habitual REM sleep prior to trauma predict higher likelihood of PTSD and PTSD symptoms after highly stressful experiences? This is what the current pilot study was set to explore, trying to fill in the gap between the field survey studies and the laboratory studies. To examine this question, we planned a longitudinal study using a population of emergency responders, like firefighters and paramedics, who are routinely exposed to highly stressful and sometimes dangerous experiences as part of their job. We recruit these emergency responders just before they begin their training course and measure their habitual sleep for a week using physiological sleep monitoring devices. Then, through a battery of online surveys, we assess their current stress responses to recent events, as well as various other factors that could be relevant. We then repeat these assessments along the months following the conclusion of the course and beginning of fieldwork. This allows us to explore whether habitual REM sleep is able to predict who among them would be more vulnerable to excessive stress responses following exposure to job-related stressors. We monitored sleep using an EEG device that measures electric conductance in the scalp and can differentiate REM sleep from other sleep stages. Importantly, this device is designed for home use and can therefore be self-applied by the subjects for multiple nights. We measured stress responses using standardized tests for PTSD, job satisfaction, and burnout scores, and also asked subjects if they recently experienced any highly stressful events. Additional measures like demographics, mental health, and personality traits were also collected. So far, we have recruited 16 participants, including 11 firefighters from the San Antonio Fire Department and 5 paramedics from the Emergency Medical Services in Austin. We will present results from 10 firefighters who have completed 2 assessments so far at baseline and right after the end of the training course before starting their field work. Consistent with our prediction, we found that the percent of habitual REM sleep measured before the training course showed a trend for being negatively correlated with the increase in stress responses to recent stressful events. In other words, subjects who regularly spend higher percentage of their sleep in REM tended to have smaller stress responses for events happening during the training course. We also found that the percent of habitual REM sleep was positively correlated with subjects' feeling of compassion satisfaction from their job. For example, reporting that they feel satisfaction from helping others, and so on. So to summarize the results, as we predicted, percent of habitual REM sleep was associated with weaker stress response and more compassion satisfaction at the end of the firefighter training course as compared to baseline. Note, however, that those 2 effects are only related to the 6 months before and after the course. We are yet to measure those subjects after they begin their field work when real stressors are expected to appear. What are the next steps in this research? First, we need to conclude the pilot study, recruiting some more subjects and follow up all subjects 6 months into their fieldwork. But we also plan to extend the study to include a larger population of emergency responders and add brain activity measurements when subjects are asked about the recent experiences to try and clarify the neural mechanisms mediating the effects of REM sleep. To conclude, I'd like to acknowledge my lab personnel who worked on this project, particularly my graduate student, Emerson Larius, and the support of the pilot project research grants at UT Health Science Center in Houston. Thank you for listening.
Hello, everyone. My name is Dr. Bethany Schulte, and it is my pleasure to be here today to talk just a little bit about a pilot project on heat stress and kidney function among construction workers here in Texas. So we all know that outdoor work puts you at a higher risk for experiencing heat-related illnesses, and construction workers do have the second highest risk of experiencing a heat-related fatality at work. They only comprise about 6% of the labor force in the US, but they make up 36% of all heat-related fatalities that happen on US workplaces. This issue is a really big issue for construction workers, and especially for immigrant construction workers, who have, many of whom have told me that when they're not getting adequate water breaks and shade on the workplace, they feel like they're being treated worse than an animal or worse than a machine. So this project is being done in collaboration with a worker center that primarily works with undocumented construction workers. And we've been recruiting about 20 construction workers in Austin and Houston, Texas. That recruitment has been done through online Zoom meetings, through directly calling workers, and then also workers have been inviting their colleagues to participate. And something really interesting about this is that everyone has a heat stress story of a time when they got sick. Workers have been pretty eager to participate, but the biggest hurdle has been workers, especially residential construction workers, often move on a daily basis to several hours outside of the city. So highly migratory and very long work hours has made some recruitment challenging. In this study, I'm using a Zephyr bioharness to record heart rate, respiration rate, core body temperature, and some other measures. Really every second, it's generating about 300,000, 400,000 data points a day on each participant. Participants are also using an eye button sensor to measure the outdoor temperature. So why kidney function, you might ask? Well, kidney function has, in the last 10 years or so, there's been a lot of research showing that there's a really strong connection between workplace heat stress, chronic dehydration, and having damage done to the kidneys long-term through that. So in this study, I'm seizing the opportunity to be a little bit creative, and what we're doing is we're looking at protein in the urine using a point-of-care device. And I really wanted to test this method because urine analysis is much more acceptable to Latino immigrant workers than blood draws. So for the logistics of this, I am meeting workers before their shift and after their shift, either at their home or their work site or somewhere nearby, and I collect urine samples, and workers are also completing a brief survey at the end of the day. So I still am doing some data collection for this project, which has been interesting in the middle of a heat wave, but I just wanted to share a couple of slides on participants. So what I'm seeing is honestly is that workers, the core body temperature and reporting of heat-related illness symptoms don't necessarily line up. Basically, all the workers that have participated go from seriously dehydrated to severely dehydrated every day. So they're kind of in a constant state of dehydration, it looks like. One worker has had some really concerning core body temperature measurements that I do not think are artifacts of the data after I did some data cleaning. And this participant reports experiencing kidney stones every month. So here's just another one. Many of them are hovering kind of right at 38 degrees Celsius, which would be 100.4 Fahrenheit. Workers have been really interested to collect their biometric data and to learn just how hot it is in the workplace. And again, the biggest, I think, scalability issue for the study is really figuring out just how to do it with such migratory mobile workers. Even though the study is small, I think it's a really critical time because we are having a national discussion right now on a federal heat stress standard. And this is really critical for those of us who are in the South and who advocate for workers in the South, because we have no enforceable protections for workers, really. Workers don't have a right to take breaks by and large. So this is a big concern. It's my hope that this material could be used to build up to a study looking at productivity of workers and showing that workers are more efficient and more productive when they're given adequate rest and water. I always like to recognize Roni Granillo and the Granillo family. Mr. Granillo was a 25-year-old construction worker who died a few years ago in Dallas doing flooring work on new suburban homes. And his family has been very strong advocates for heat stress protections in the workplace. And I know that myself and many people at Workers Defense Project really respect and admire that family and do that work for them. So I just wanted to thank Workers Defense Project members, the organizers and staff that have been helping with this project. And I also wanted to acknowledge Dr. Dufresne and Dr. Rodriguez for loaning me much of the equipment in order to do this study. Thank you.
Okay, well, thank you so much. These were some great presentations. Looks like we already have a few questions for Dr. Lerner. The first one is that, did you also look at the total sleep duration and how might these be related?
Yeah, so just to make sure that you hear me.
Yes.
Okay, good. Yeah, so we did look at it. Our prediction was that both would be correlated, both the percentage and the total time, total amount in REM sleep. So far, we only found the expected correlations in percentage and not in total amount of REM sleep. The percentage is considered to be a little better measure because people need different amounts of sleep. And so the idea is how much of that sleep is going into the stages that are important, let's say it like that. And that way it's considered to be slightly more predictive. But nevertheless, we would expect to find some correlation with the total amount of sleep. And I wonder if we didn't find it because there is a greater variability in terms of how much these firefighters sleep. And that can be seen as noise, right? So it would obscure the correlation. Then we need more than 10 subjects in order to uncover it.
Okay, and what impact would adding the heart rate variability as a monitored biometric play in the sleep PTSD vulnerability study?
Yeah, so I don't know. Heart rate variability is often used together with actigraphy in order to say some things about sleep when you don't use a device that is actually measuring from the brain. So it's kind of like shortcuts which are not very accurate to say some things about sleep stages. Because I'm using a headband that is actually measuring directly from the scalp, I don't need heart rate variability in order to directly measure sleep stages. I'm not sure if heart rate variability has its own merits unrelated to sleep staging. I'm not an expert on heart rate variability, so I'm not sure, but at least from the research question that we're interested in, heart rate variability should not add too much because we just got better measures.
Okay, just to follow up, this was something that I was thinking when you were saying you also asked a few questions on mental health and personality traits. So what were those? Just curious.
Yeah, so in terms of mental health, first of all, we got a demographic form, not like a screening form, kind of like making sure that we're not, that they're not suffering from any serious mental illness and they don't have mental illness running in the family. So that's kind of like an exclusion criteria. In addition to that, we're having the DRDI, the suicidal scale, in the measures. And we are thinking of adding also this TIE, which is kind of measuring a trait level anxiety, but we haven't done that yet. These are all considered to be covariates, right, which should be able to help us uncover the effect. But the results that I presented are actually, I guess, strong enough to appear even without trying to control for that. But of course, we'll need to advance the statistical model more, especially when we get few more subjects, right, to try and see if the correlation holds while controlling for all these factors, or if it gets stronger, as I suspect it might.
Okay, and the last question we see here was that did you look at sleep both on and off duty?
Yeah. So in terms of measuring objective sleep measures, that's REM sleep, for example, like physiological measures of sleep, we're only looking at the very, very beginning of the period of the study when before they even start the training regime. So that's definitely off duty. It's before they even start to train, and that's because our research question is particularly about trait levels, right? Like how much sleep I have in general, like a risk factor, right? And would that predict vulnerability? So intentionally, it's not about sleep during the duty. However, we also, in our surveys, we also measure sleep based on self-reported sleep logs, and they will also play as a covariate. So, for example, if somebody really had atrocious sleep right during duty, and that may affect the anxiety, then we would not want to know that in order to control. But again, then you get into issues where they're, let's say, they have like whether the sleep is bad because they experience severe stressors, or is it kind of like because they had bad sleep just before the stressors, then that causes. So it's a problem of causality. But when we're looking at the sleep before they even started the training, then we can kind of say something about causality as long as we are controlling for other covariates.
Okay. So since there's a prioritized focus on stressors and PTSD, and you being located in San Antonio, have you thought of expanding this study outside emergency responders? Like there's Air Force Base, veteran population, and military personnel that are pretty much often the populations that are being studied for topics like this. So is that in the works, or are you considering?
The answer is obviously, and not only obviously, we try to start with that. That actually was the original thought. And we made some contacts, and it turned out that doing such a study in military personnel, we'll need to measure their sleep just before they start training. So actually before they enlist officially, and it turned out to be pretty difficult logistically. And I guess we would really need like a serious amount of cooperation from stakeholders, and it was more difficult to find than looking at civil institutions like the firefighters, and that's why we at least started there. We are thinking about expanding it to police officers and to other firefighter departments, but if we'll have the opportunity to be able to extend it to military personnel, we would, absolutely.
Great. We do have a few questions for Dr. Alcauder, and one of them is, did you obtain any information on underlying medical issues or medications that might affect the state of hydration for workers?
Yeah, so I did screen participants and none of them have diabetes. I didn't exclude people with high blood pressure because I wasn't too sure if people would know that. And that's what I'm finding, that participants do have high blood pressure, even very young participants, and they didn't know that. So that could be an issue. And then I do ask a survey every day, and that survey is derived from the survey that Dr. Jimeno and Dr. Delcos used in Central America. And so it asks about certain medications that they took during the day and every beverage that they drank in the last 24 hours.
Perfect. And another question was that did the participants indicate use of caffeine and energy drinks? The report of kidney stones makes me wonder what factor these drinks may play in dehydration and kidney disease.
Yeah, some participants did report drinking coffee. Nobody drank energy drinks, but by and large, they are drinking water or Gatorade throughout the day. And other research on this topic in Central America hasn't found a big association between the type of drink and dehydration and kidney function. It's been much more about just being able to keep up with your water and electrolyte needs. It's just so hard when you're working pretty hard in 100-degree heat all day.
Okay, thank you. Dr. Sinha, one of the points that I was actually a little surprised with was how you identified higher risk perception in non-operators versus operators. So would you mind explaining like the roles, because operator pilots and non-operator pilots, how these roles particularly differ in that work environment, and what do you think are the reasons for differences in the perception between these two?
So these operators are basically the business owners. They have the certificate to apply. So they own the business and they decide perhaps when would the applications take place. They are primarily dealing with the contracts. And then they hire these non-operators who are just the pilots who help them fly the aircraft. So we do not really know what causes the divergence, but we feel that the ownership might be one of the variables that does cause that divergence. Because as owners, you might want to make more profits and you want to fly even if the weather is not as conducive. So the pilots, they would feel the weather is not as conducive and they do not want to fly. They feel the risks are higher. However, as business owners, the profit motivation is of course higher with them, and they might want to still fly and suggest that these risks are not as high as the pilots may perceive them to be. So that's one reason we feel the perceptions diverge. But of course, more research is needed in a treatment control environment, perhaps, to figure out what are the causal factors.
Okay, yeah, and this is what I was wondering too, and Dr. Moore was just asking, are these owners, the operator pilots, that's what you use the term pilots, right? So are they all of them trained as pilots, or not all of them in among those who you interviewed?
Yeah, that's a great question. So basically, the data set that we have has 3 different kinds of mutually exclusive groups. So we have the operators who are not pilots, they're just operators. Then we have operators who are also pilots. And then lastly, we have pilots who are not operators. In this research, we have restricted our sample to everybody who's pilot, but divided between operators and non-operators. So the operators that we are looking in this research are also pilots, but they also own their businesses.
Okay. Perfect. I think there's one more question for Dr. Lerner. Have you considered, I think you answered this based on the question about the Air Force Base, but I'm just reiterating it. So have you considered other chronically sleep-deprived workers in dangerous jobs like fishermen, for instance? I know you told about police and also potential.
So I never considered fishermen, I have to admit.
No, yeah.
I don't know the data about fishermen. I mean, many things can be dangerous, but how dangerous and how often do they actually encounter life-threatening or extremely stressful situations? That, I mean, that is an essential element. Also, I want to point that we're not interested necessarily in sleep-deprived populations. I mean, they might be sleep deprived during the work or sometimes, but we're interested to know, to be able to capture their sleep before they start. So, for example, with fishermen, I would try to see how their sleep is before they become fishermen, right? Before they start the job routine, to get some kind of baseline sleep, and then follow them up for a year. And I guess it might be more difficult with fishermen to catch them just before they begin their trade, rather than, firefighters or police officers, where there's a training that starts and we can catch that through the institutions. So, I mean, I would definitely not rule that out, but it has to work out logistically. Right?
Dr. Lerner, we have some experience in the Southwest Ag Center in working with commercial fishermen. So there could be some opportunities to look at a collaborative effort there. One of the interesting aspects of commercial fishing is they do have seasons, and so you could measure them in the sort of the fishing season and the non-fishing season, and try to make some comparisons between those two, and that might be an interesting study to consider. So if you decide to pursue that, you might want to reach out to us and see if that might be something that would be a potential feasibility study within our center.
I would consider it, definitely. So just email you. Yeah. Okay. Thank you.
Yeah, Dr. Kauder has a comment that many agricultural workers and truckers also face severe sleep deprivation and high-risk workplaces. And that one of our friends trucks milk between dairies and works 16 to 18 hours a day, 7 days a week. And so there are a lot of populations that are affected by this. So I guess that's one more comment on expanding your study idea to different occupations, I guess. So
yeah, no, it's all good ideas. Again, it needs to have this ability to measure sleep as a baseline when they're not sleep deprived, and that's always kind of like a logistic necessity.
Okay. Any more questions? So for Dr. Sina, the National Agricultural Aviation Association, right? There's and I think and this was something I was looking at while you were presenting. So can you comment? I just read about the self-regulating application and flight efficiency. So the project SAFE.
Yeah.
And you were talking about the perception, how it aligns with the safety hazards. So do you have some comments on the role of this, the NAAA, the National Agricultural Aviation Association, and the project SAFE, as to how it relates to your presentation and whether that's something that the audience should know about?
So, I mean, I first want to say that the whole situation in agricultural aviation, the occupational hazards that they face on a day-to-day basis, is not something that's been documented very well in the literature so far. People are not very aware as to when these kind of treatment, these fertilizer treatment that take place on a day-to-day basis, that is associated with the aviators facing several different safety hazards, and it's not something as documented as in fields like construction or farming, where it's as of now it's very well known that workers in these occupation face day-to-day hazards. So NAAA, I think, is doing a very good job in doing that, in kind of documenting that and creating awareness. They also have several training programs that kind of helps make the aviators themselves aware of these hazards that they face, but they do not recognize while flying the aircraft, that something like power lines or several different obstructions that they find on a day-to-day basis. They are not very aware of what is the actual risk, that how often do these result in accidents. They're not very aware of that. So NAAA, I think, is doing a fantastic job of making them aware through their trainings, through their annual trainings. And I think SAFE is definitely one of the ways that they are progressing in that direction. As far as this particular project is concerned, I think we're very grateful to NAAA for giving us the data that we needed to do this research. So this survey that they do every few years. One was done in 2011, and then the second one was done in 2018. These surveys have the maximum amount of data that can help us do these kind of research, which will facilitate further progression in this direction through trainings, awareness, and creating more opportunities for research in this area. So we're very grateful to NAAA. We actually partnered with them, and they helped us with their survey data from both waves. So we have a bunch of data. There's still so much that we can do with that data. As a pilot project, we utilized two waves of that data, but we are trying to see if we can link data from 2011 to 2018. Those data are not linked on a participant-to-participant basis. So far, we have evaluated those data as separate waves. So going forward, we're trying to see if we can link both of those data sets and try to see how has risk perception changed over time. So those are some things that we're trying to look at through this research. Yeah.
Sure, it must be a challenge to identify those participants from.
Yes, it is.
Yeah.
It is, yeah. Which is why we are not making comment on how their risk perception has changed on an individual level, because we do not know if that participant in 2018 is the same as 2011. And we specifically, NAAA said in their survey that they're not going to link that data, but we're trying to change that. We're trying to see if we can go back and link those data so that we can get more information out of those surveys.
Dr. Alcouter, we have one more question. Did you ask workers about access to water and time to take breaks? Do you have any way to measure fluid intake during the day?
Yeah, so I'm not objectively measuring fluid intake, but I am asking them the frequency of how often they drink water throughout the day, so every 30 minutes, every hour, etc. And breaks, no. Although I can kind of see that in the data with the Zephyr bioharness, I can see when their heart rate goes down. So it may not be a full break, but I can see when they're physiologically resting. But I am not tracking breaks, but yeah.
But in general, you said they were all showing significant or severe dehydration during the workday, right?
Yeah, in the morning and after. It was, usually their urine specific gravity was at 1.03 or 1.02, so they were all kind of already, they just stayed dehydrated for the whole.
So they're starting the day dehydrated already.
Right.
Have you looked at any interventions related to sort of preparatory drinking of fluids in the evening and prior to their shift?
Prior to the shift, no. I do know of some intervention studies looking at it during the workday, trying to get workers to drink more water. And I think the most successful ones have been by providing workers camelbacks with water so that they don't have to stop. But then you're not getting any rest, so that their heart rate isn't coming down on the really intensive occupations. But that would certainly be interesting to look at. I mean, I've talked to workers and I've told them, you're dehydrated, try to drink more water. But a lot of their feedback is like, if I drink more water, I feel sick. They don't feel like they can physically intake enough water and be that physically active without getting nausea or cramps from fluid intake.
Yeah, it'd be interesting to see what the results look like if they started the day not already dehydrated. So it'd be an interesting study to do, I think.
Yeah, it's been concerning. I had on the second day of data collection, somebody was having a lot of HRI symptoms, and I had to refer them to medical care. And several of them have had blood, traces of blood in their urine, which is also concerning. So, yeah.
Well, so if you have no more questions, I guess, Dr. Moore, we can call it off a few minutes early, and since we're also close to the lunch hour. So Well, thank you everybody so much. This was a great session, and the entire symposium was fascinating. It was really nice to see all the presentations. Would like to thank Dr. Schulte, especially for a wonderful keynote. I don't think he's here anymore, but we'll make sure to convey the message to him through Dr. Moore. Yeah, we would like to thank you all for being a part of this symposium, to all the presenters as well as all the attendees. And we look forward to more fascinating projects over the next year and coming up again with some groundbreaking research in occupational health next year. We do have evaluations that you will receive in the email, so make sure you fill up those evaluation forms and send it back to us so our team can work on getting the CEUs issued back to you. If you have any questions, please reach out to Ms. Sylvia Santiago as well as Amanda Wickman if anything is on from both the institutions if you have any questions. But with that, I'll pass on to Dr. Moore for some concluding statements as well as Dr. Casanova. I think you're muted.
I'm muted, yeah. Thank you to everyone. As Janelle said, special thanks to Sylvia. She's really been, you know, a driving force in the background to make sure that we get all of our ducks in a row and managing the feed and these kinds of things. So really appreciate her her hard work. And thanks to all the researchers who presented their projects today. Thank you for the work that you're doing. Hope that you'll continue to keep us apprised of you know, your research and how it progresses and new funding that you're obtaining and publications that come from your research. You know, the work that you're doing is very very interesting and important, and I think you'll continue to find success in applying that. We will continue at the Ag Center as well as I know you know, Janelle as well at the ERC will be continuing to look for you know, opportunities to fund projects. I would hope that you would be an active part of recruiting for us. So would encourage you to you know, be reaching out to your colleagues, to students that you're working with, to others that might be interested in submitting a proposal for one of our centers, and you know, keep people apprised of what's going on. Also, just helping us, you know, as we try to connect with new institutions, with new individuals, any leads that you can provide to us to help us with getting in contact with new individuals. We would definitely value that. And thank you so much for your hard work and your dedication. Dr. Casanova, did you have any last minute comments you'd like to make?
Yes, thank you. So thank you to Houston for hosting with the WebEx. I think that this is probably one of the most seamless conferences I've been in since COVID. You know, so they've kind of mastered WebEx, so we don't even try. I also wanted to say that I'm so impressed with the just all of the projects. These pilot feasibility studies funds are awarded to each center. And, you know, I think I'm not sure if the ERCs have an option, but I know the ag centers have an option to leave that part out of our center-wide application. And I just can't see us ever doing that. This is a way that we bring in junior researchers, folks that have never heard of occupational safety and health, folks that have never focused on agriculture. And so I think that the work you're doing is just incredible. And the idea is that you take this pilot data and use that to leverage for bigger funds. And you know, so anyhow, it just great job, everyone. I'm just really impressed at the level of work and how robust everyone's research is. It's just really, really good. I'm humbled. So great job.
And just to re-emphasize, both of these centers, we work collaboratively throughout this pilot projects process that happens over the entire year and not just the symposium. So feel free to reach out to both of us, me as well as Kevin, if there are projects that you think that are better fit to just agricultural needs and occupations specific to that spectrum. We'll be happy to route your projects that way and vice versa. So we have funding opportunities going on both the ends around the year, sometimes even twice the year for one of these centers. So if you or your colleagues are interested in conducting pilot feasibility projects, just reach out to both of us. And I believe that's the whole and sole reason for this collaboration, and it has been successful so far. Yeah. Okay, so with no more questions or comments, thank you all again, and we really hope you enjoy the rest of your Friday. And